Good evening and welcome to all speakers, delegates, and respected doctors. We would like to start today's session. So today's session, we have a Dr. Arvind Kumar Pandey, who is MCH CVTS, and he is Assistant Professor, Department of CVTS, IMS BHU RLC. He is going to moderate the session, upcoming session. So Dr. Arvind Kumar Pandey sir is MBBS from IMS BHU, MS from IMS BHU itself, and he's currently is a assistant consultant CVTS. And he's worked as a various places like Medanta, the Medicity. Currently he is at BHU. He's having experience of adult cardiac surgeries, coronary artery bypass, grafting, valve screenings, and he's having experience of pediatric cardiac procedures, AST, VST, TOF, closed cardiac procedures, fluorescent procedures, and peripheral vascular procedures. So we would like to start today's session. So today's session, we have a Dr. Arvind Kumar Pandey, who is MCH CVTS, and he is Assistant Professor, Department of CVTS, IMS BHU RLC. He is going to moderate the session, upcoming session. So Dr. Arvind Kumar Pandey sir is MBBS from IMS BHU, MS from IMS BHU itself, and he's currently is a assistant consultant CVTS. And he's worked as a various places like Medanta, the Medicity. Currently he is at BHU. He's having experience of adult cardiac surgeries, coronary artery bypass, grafting, valve screenings, and he's having experience of pediatric cardiac procedures, AST, VST, TOF, closed cardiac procedures, fluorescent procedures, and peripheral vascular procedures. So we would like to start today's session. So today's session, we have a Dr. Arvind Kumar Pandey, who is MCH CVTS, and he is Assistant Professor, Department of CVTS, IMS BHU RLC. He is going to moderate the session, upcoming session. So Dr. Arvind Kumar Pandey sir is MBBS from IMS BHU, MS from IMS BHU itself, and he's currently is a assistant consultant CVTS. And he's worked as a various places like Medanta, the Medicity. Currently he is at BHU. He's having experience of adult cardiac surgeries, coronary artery bypass, grafting, valve screenings, and he's having experience of pediatric cardiac procedures, AST, VST, TOF, closed cardiac procedures, fluorescent procedures, and peripheral vascular procedures. So we would like to start today's session. So today's session, we have a Dr. Arvind Kumar Pandey, who is MCH CVTS, and he is Assistant Professor, Department of CVTS, IMS BHU RLC. He is going to moderate the session, upcoming session. So Dr. Arvind Kumar Pandey sir is MBBS from IMS BHU, MS from IMS BHU itself, and he's currently is a assistant consultant CVTS. And he's worked as a various places like Medanta, the Medicity. Currently he is at BHU. He's having experience of adult cardiac surgeries, coronary artery bypass, grafting, valve screenings, and he's having experience of pediatric cardiac procedures, AST, VST, TOF, closed cardiac procedures, fluorescent procedures, and peripheral vascular procedures. So we would like to start today's session. So today's session, we have a Dr. Arvind Kumar Pandey, who is MCH CVTS, and he is Assistant Professor, Department of CVTS, IMS BHU RLC. He's going to moderate the session, upcoming session. So Dr. Arvind Kumar Pandey sir is MBBS from IMS BHU, MS from IMS BHU itself, and he's currently is a assistant consultant CVTS. And he's worked as a various places like Medanta, the Medicity. Currently, he is at BHU. He's having experience of adult cardiac surgeries, coronary artery bypass, grafting, valve cleaning, and he's having experience of pediatric cardiac procedures, AST, VST, TOF, closed cardiac procedures, fluorescent procedures, and peripheral vascular procedures. So we would like to start today's session. So today's session, we have a Dr. Arvind Kumar Pandey, who is MCH CVTS, and he is the assistant professor, Department of CVTS, IMS BHU Varanasi. He is going to moderate the session, upcoming session. So Dr. Arvind Kumar Pandey sir is MBBS from IMS BHU, MS from IMS BHU itself, and he's currently is a assistant consultant CVTS. And he's worked as a various places like Medanta, the Medicity. Currently, he is at BHU. He's having experience of adult cardiac surgeries, coronary artery bypass, grafting, valve cleaning, and he's having experience of pediatric cardiac procedures, AST, VST, TOF, closed cardiac procedures, fluorescent procedures, and peripheral vascular procedures. So we would like to start today's session. So today's session, we have a Dr. Arvind Kumar Pandey, who is MCH CVTS, and he is the assistant professor, Department of CVTS, IMS BHU Varanasi. He is going to moderate the session, upcoming session. So Dr. Arvind Kumar
is evaporating. The cardiac effects of evaporating are specific to the SA node, and the drug has no effects on the blood pressures as it does not reduce the contractility of the heart like other beta blockers or CCPs. It has no conduction defects, cardiac conduction defects. Myocardial contractility is not affected, or ventricular repolarization is also not affected. The patients on evaporating therapy should have resting heart rate of at least 70 beats per minute. Administration of evaporatin to heart failure patients significantly reduces the risk of death from heart failure by 25% and risk of rehospitalization by almost 25%, and it is statistically significant also. Next slide, please. With the background that diagnosing frequency is an important factor influencing medication compliance in the patients with heart failure, which in turn is interspective in achieving the desired therapeutic outcome. Proficient study was designed performed and finally published by the year 2020. Here, the efficacy and the safety of evaporatin prolonged release once daily versus evaporatin immediate release twice daily formulations in the patients with stable chronic heart failure with systolic dysfunction was assessed. Next slide, please. The recent J-shift study showed that systolic blood pressure remains unchanged when the heart rate was reduced with evaporatin. This maintains the hemodynamics during heart rate reduction in and is essential to achieve future cardiac reverse remodeling and better survival. The prolonged release formulation of evaporatin once daily is in heart rate management. The proficient study was designed to assess non-inferiority of this new once daily evaporatin prolonged release compared with the conventional twice daily evaporatin formulation in the efficacy and safety parameters in patients with stable chronic heart failure and systolic uh, uh, dysfunction. The baseline character of the patients were as follows. Almost male-female ratio was almost similar, and the age group was 18 to 70 years. They were currently receiving stable dose of evaporatin instant release preparation 5 milligram or 7.5 milligram BD, concurrently receiving standard care for stable chronic heart failure, that is guideline directed medical therapy, documented stable chronic failure of NYHA class 2 to 3 for more than 6 weeks at the time of screening. The patients were having sinus rhythm with clinically stable heart rate of more than 50 as assessed automatically by the standard 12 lead ECG and documented LVF of less than 40%. Next slide, please. Proficient was randomized, double-blind, double-dummy, multi-centric phase 3 non-inferiority study conducted from May 2018 to April 2019, which included patients from 21 centers across India. And the primary objective of this study was primary efficacy endpoint and non-inferiority margins to be assessed in this study. Next slide. The secondary objective variability incidence of the heart failure was incidence of the heart failure, hospitalizations, CV mortalities, and all-cause mortalities. Next slide, please. Yes. The major exclusion criteria were as follows. Recent myocardial infarction, coronary revascularization in these patients, stroke or transient ischemic attacks within 3 months of time, or with a transplanted heart, implanted PPI, implanted PICD, or CRT devices. Sorry. The permanent atrial fibrillation of flutter or any other cardiac arrhythmia which could interfere with the function of SA node, sick sinus syndrome, sinoatrial block, congenital long QT or treatment with QT prolonged medication, second degree and complete AV block, unstable or acute heart failure, and unstable angina. The severe or uncontrolled systolic as well as diastolic hypertension and hospitalization for worsening heart failures. Schedule for the coronary patient is scheduled for coronary revascularization or requires surgery for valvular heart disease during this period. And of course, the last exclusion criteria was pregnant or lactating women. Next slide, please. So the study consisted of 6 visits. The visit 1 was the screening period up to 7 days and eligibility of inclusion. Visit 2 was run-in period of 8 days. Ivabradine instant release 5 milligram or the 7.5 milligram was administered to all the patients during this run-in period. And the visit 3 was a day 0 randomization. The eligible patients were randomly allocated to the treatment group in 1:1 ratio. Ivabradine instant release 5 or 7.5 milligram twice daily, or ivabradine PR prolonged release 10 milligram or 15 milligram once daily dose. The patients who were willing to participate in 24 hours ECG Holter analysis underwent 24 hours Holter ECG monitoring on day 1 and day 90. A window of 3 days was allowed at visit 4th, which was day 16, visit 5, which was day 46, and visit 6, which was day 91. The mean resting heart rate was measured at each visit based on 3 consecutive ECG recordings within 3 minutes after 10 minutes of initial rest in supine position. Next slide, please. Yes, this one. So these are the previous one. Yes. These are the centers. You can see the BL Kapoor Hospital, Maharaja Agrawal Sen Hospital in New Delhi, SGPGI, Lucknow, AIMS. These are the all 4 zones: the north, west, south, and the eastern zone, DM Birla Hospital and Calcutta Medical College Hospital. These were the centers, 21 centers where the patients, the study was performed. Next slide, please. So, what were the study results? Next slide. The mean change in heart rate in 2 groups was less than the pre-specified margin of 6.5 beats per minute and at 95% confidence interval. Thus, the primary objective was met and the non-inferiority of ivabradine prolonged release to ivabradine instant release was actually established. Next slide, please. This one is the same, and it is also showing the same thing. You can see here the non-inferiority of the PR prolonged release formulation to immediate release was established by this diagram. Next slide, please. So the safety outcome included the incidence and the severity of adverse event, serious adverse events, and the treatment emergent adverse events. The incidence of hospitalization for worsening heart failure over other cardiovascular reasons and mortality rates were also assessed at the end of 3 months compared to the baseline. Next slide, please. The ivabradine PR release has a good safety profile and is at par with the ivabradine instant release. No new safety concerns were seen. None of the treatment emergent adverse events were unexpected, and there was no clinically significant findings in the lab parameters, vitals, and examination findings. Next slide, please. A total of 39 treatment emergent adverse events were reported in 29 patients in both the PR and the immediate release groups. The majority of the TEAE were related to the study design. So it was non-significant actually. Next slide, please. So what were the exploratory end results? The incidence of the hospitalization for worsening heart failure, other CV mortalities, all-cause mortalities from baseline to end of 3 months. Only one subject in instant release arm was hospitalized for worsening heart failure and mortality due to CV risk. whereas same was not observed in the PR release arm. And for patients in the Holter subgroup, to compare the change in the heart rate measured by the automated 12 lead ECG versus heart rate measured by the 24 hours Holter ECG, the study demonstrated no significant difference in the change in heart rate from baseline to 3 months time. So the study was successful and the endpoint was non-inferior in uh, prolonged release formulation in as compared to instant release formulation, and this has a very significant this was a very significant finding because it reduces the pill burden also. Next slide, please. The study data demonstrated no significant difference in the resting heart rate, mean 24 hours heart rate, mean heart rate awake, mean heart rate asleep at baseline after 3 months treatment of the evaporating prolonged release or evaporating instant release. Next slide, please. Yes, the study results support the use of evaporatin prolonged release once daily formulation as an addition option of evaporatin twice daily, used in the management of stable chronic heart failure with systolic dysfunction. Next slide, please. Thank you. So the heart failure is a common debilitating condition that is associated with a complex drug regime, comorbidities, frequently requiring lifelong management. High medication burden is often observed in patients with heart failure, which may be attributed to multi-drug treatment with the multiple dosing regimes. This polypharmacy and high pill burden may be overwhelming for the patients, resulting in medication non-compliance. Here, the take-home message for all is, since the once daily PR formulation of evaporatin is non-inferior to evaporatin instant release twice daily regime, when added to the background guideline-directed medical therapy in patients with chronic heart failure, evaporatin prolonged release formulation should and can be used for better compliance of the patients. Thank you. And now the session is open for questions, if any.
May I ask a question?
Yes.
Yeah, good evening, sir. Sir, in your clinical experience, which are the patients where you mainly use evaporatin?
Evaporatin is mainly, I am using it in, actually first step, I am using it in ADHS patients, where the patient is hemodynamically very unstable and patient is on inotropic support. Then we are using it at first point. Where we cannot give beta blockers instantly and we have to control the heart rate. The other uses are when the patient is on maximum tolerable dose of beta blocker and still the heart rate is more than 70, then we should use evaporatin, add-on evaporatin. It might be prolonged release or it might be instant release drug. The other thing is, if the patient is not at all tolerating beta blocker, then we can use evaporatin. But overall, evaporatin is a novel drug and it is a sort of cardiac tonic, and it should be more frequently used than it is used right now.
Thank you, sir.
Any other question?
Sir, what was the cutoff heart rate you mentioned when the patient is on beta blocker, and above what heart rate you use the ivapabratin as an add-on?
We try, in our cardiac patients, we usually maintain a heart rate of below 70, 60 to 70. So if the patient is on maximum tolerable dose of beta blocker and the heart rate is still above 70, then we start using ivapabratin, because it does not cause any hypotension, and so it is very safe to use ivapabratin in these kind of patients.
Okay, sir. Thank you, sir.
Okay.
Hello. Dr. Ahmed. Hello, Ahmed boss.
Yes.
Just I want to ask one thing, that can ivapabratin be combined with beta blocker or not?
Yes, that I definitely said. If the patient is on maximum tolerable dose of beta blocker, the patient is having a beta. If the patient is
Yeah.
just a minute, hold on. Hello. If the patient is on maximum tolerable dose of beta blocker, that is, if the patient is taking 5 milligram of beta blocker, and beta blocker is definitely a better drug. Then, because the NNT of beta blocker is much more than ivapabratin. If the patient is on 5 milligram of bisoprolol and his BP blood pressures are on borderline type, then we can add on ivapabratin. If the patient is on maximum dose of beta blocker, that is 100 milligram for metoprolol or 10 milligram for bisoprolol, and still the heart rate is above 70, then we can add on ivapabratin in these kind of patients. So ivapabratin can be added to beta blockers.
Okay. So one last question. So does ivapabratin causes hypotension?
No, since the ivapabratin is IF channel blocker, which is mainly working on sinoatrial node, it is not working on left ventricle or AV node. So ivapabratin is never causing, it just lowers the heart rate, but it never causes hypotension.
Okay. So thank you so much, Dr. Amit, for such a nice presentation.
Thank you.
Okay. So now I would like to invite Dr. Shankar Shubhra Chakravarti. He's associate professor and head department of Geriatric Medicine, Institute of Medical Sciences, BHU. Dr. Chakravarti had done his MBBS from the same institute, Institute of Medical Sciences, BHU, done his MD in General Medicine from IMS BHU, participated in many national and international conferences with more than 70 publications to his credit, which are published in various journals, national and international repute. He's an adjunct faculty with Interdisciplinary School of Life Sciences, Banaras Hindu University. He's a technical expert, Pharmacovigilance Program of India, member, Research Wing, Indian Academy of Geriatric Medicine, along with principal investigator in 2 ICMR-funded projects. So I would like to invite Dr. Shankar for the next presentation.
Thank you, sir. Good evening to everyone. Thank you. Am I audible clearly?
Yeah, Shankar, you are audible here. Please carry on.
I'll be sharing my screen. I have my own, the slides I have shortened a little bit. So I'm sharing my screen.
I can see you.
My screen visible.
Yeah, it is visible. Vitamin D supplementation in type 2. Yeah. It's your voice.
Yeah, voice is clear now.
Yeah, but
Okay, so topic is vitamin D supplementation in diabetes, to do or not to do. Okay, so if we look at the status of vitamin D, we have heard this quite often that in India, despite the significant sunlight exposure, there is a significant amount of vitamin D deficiency. And this is more true in the elderly and more true in the females who are having a higher risk of vitamin D deficiency. And one study of 300 persons showed that 63% of the people are vitamin D deficient. And in fact, this is quite common in the West also. Despite them also going for regular sun exposure, and over there it's a sort of a lifestyle measure, but still there is a significant vitamin D deficiency in multiple world literature and in India. So there are several factors which contribute to vitamin D deficiency. Physical inactivity, any coexistent chronic illness or aging or dark skin pigmentation, less exposure to sunlight because of seasonal reasons or altitudinal reasons or air pollution. And there have been some evidence also that metabolic parameters which are indicative of insulin resistance may also be somehow associated with vitamin D deficiency. Although whether one is the causative factor and the other is the end product, it's not very certain at this point.
So if we look at how vitamin D affects the pathophysiology of diabetes, there have been multiple hypotheses, but probably the most conclusive thing is that vitamin D deficiency leads to a state of increased inflammation, systemic inflammatory state, and inflammation, as we know, impairs the insulin sensitivity. So it is one of the stimulants of insulin resistance in the body tissues, and that's how it will be affected. If we look at the association of vitamin D deficiency with the diabetes-related
complications, then multiple reasons, multiple pleiotropic effects of vitamin D have been suggested to have a role in the diabetes-related complications. But again, the exact pathological details of this are not clear. We will take up the individual complications after one case scenario. Suppose here we have a female, 51-year-old female called Hina, who is an accountant in a bank and has a sedentary lifestyle and a known case of diabetes since 6 years. She has a BMI of 28.7 kilogram per meter square, which makes her obese by Indian standards. And she is currently on metformin 500 milligram and glimepiride 2 milligram twice daily. No family history of diabetes. The vital parameters are more or less normal. There is central obesity, which we expected from the BMI. The fasting and the postprandial blood glucose are both uncontrolled, 210 and 278. HbA1c, you can see her age, it should be 7. The target should be 7, it's 8.5. And even the LDL cholesterol, which in diabetics we should target around 70, it is quite high, 149. The vitamin D also comes in the deficiency range. It is below 20 nanogram per ml, which makes it vitamin D deficient. That is, this patient is having uncontrolled blood sugar, increased level of LDL cholesterol, as well as vitamin D deficiency. So what are the things that the patient would be benefiting from? Obviously, she needs a tighter sugar control because she's on the younger side. I'm into geriatric practice, and for us, 60 plus is just the starting of the age. So below 60, anything is young. So she has uncontrolled diabetes, and vitamin D deficiency is another factor that's present, and we may be adding a statin to this patient also. So we'll consider how are the different ways in which vitamin D deficiency may be affecting such a patient who is also having comorbid diabetes. We'll look at the different microvascular and macrovascular complications and what is the evidence regarding them. So if we look at vitamin D deficiency and its association with diabetes patients who are having microvascular complications. So there was one important study by Uzlo Gulari published in BMC Endocrine Disorders. And it was seen that those patients who had mean 25 hydroxy vitamin D levels. Now, this is the normally measured. Whenever we advise for vitamin D, we advise for 25 hydroxy because this is the long-lived form of vitamin D in the circulation. So, mean 25 hydroxy vitamin D levels were seen in patients who are having type 2 diabetes. And it was seen that those who are having microvascular complications, they were having a lower level of vitamin D, and the p-value was significant. That means this is statistically significant difference. Similar was the case for nephropathy. Those who were having present nephropathy, they were having a lower level of vitamin D. The same association was, however, not found in case of retinopathy and neuropathy in this particular study. So, from this study, it could be concluded that vitamin D deficiency is more common in diabetic patients who are having a composite of microvascular complications or who are having nephropathy. We look at retinopathy. There have been some studies, and there have been 2 meta-analyses of observational studies, and they have both shown that vitamin D deficiency among diabetes patients is associated with the 2 times. That is, one meta-analysis showed 2 times, and another one showed 1.23 times significantly increased risk of diabetic retinopathy. So we can again conclude from this study that a significant association exists between vitamin D deficiency and development of diabetic retinopathy in diabetic patients. The third microvascular complication after nephropathy and retinopathy will take up is neuropathy. And again, there have been observational studies which have shown that vitamin D deficiency is associated with higher incidence of diabetic peripheral neuropathy and greater symptom severity. There has been a meta-analysis which has shown that vitamin D deficiency is independently associated with a 3 times increased risk for the development of diabetic peripheral neuropathy in type 2 DM patients. So we see that there have been multiple studies which have shown that low levels of vitamin D are associated with a higher prevalence and maybe a higher symptomatology of all the 3 diabetic microvascular complications: neuropathy, nephropathy, and retinopathy. So there is another set of diabetic complications which are the macrovascular complications, and if we look at the levels of vitamin D in patients who are having macrovascular disease, then also we find that those patients who are having lower levels of 25-hydroxyvitamin D, they have a higher risk of developing macrovascular disease. Many of these studies have been summarized very nicely in this review article written by Grammatiki and others, published in Hormones. We can draw a general conclusion that in patients like Hina, the case that we described, where vitamin D is a coexisting morbidity with uncontrolled diabetes, there may be some benefit of vitamin D in order to control the different micro and macrovascular complications in such a patient. The question then becomes, can vitamin D supplementation benefit patients like Hina? So am I audible till here clearly?
Yeah, sir, you are clear.
Thank you. So now we come to the different studies which have examined the role of supplementation. Till now, we are seeing the studies where vitamin D deficiency is associated with, although the causal links could not be found in all cases, but it was found to be associated with the different micro and macrovascular complications. So now we look at whether there is any study evidence showing that if we actually supplement vitamin D in these patients, there will be some benefit. So here we take up the individual microvascular ones, diabetic retinopathy. So there is currently no indication, because there is not sufficient proof for vitamin D supplementation in an isolated patient of diabetic retinopathy. So although there has been some correlation shown, but supplementation is beneficial is still not conclusively proven. If we look at benefits in diabetic neuropathy, so there is some evidence, studies have shown that oral vitamin D supplementation does improve the neuropathic symptoms by 50%. Again, we must remember there may be some confounder, because vitamin D deficiency itself results in muscle symptoms, which may sometimes mimic the different vague neuropathic symptoms. And therefore, symptomatic benefit may be expected, but the controversial issues such as what should be the target vitamin D levels and how much dose we must be supplementing in such patients, that is not very clear till now. If we look at nephropathy, there is evidence that vitamin D deficiency can have significant impact on albuminuria, but vitamin D replacement for prevention of diabetic nephropathy in clinical practice cannot currently be recommended, because again, the conclusive evidence is not available. And same for macrovascular complications. prospective studies have failed to demonstrate any benefit from vitamin D supplementation in reducing the incidence of cardiovascular events and diabetic macrovascular complications in patients of diabetes. So what we get from this is that there are quite a few studies which are showing that low levels of vitamin D are associated with the different micro and macrovascular complications. But again, we are not having yet conclusive proof that supplementation of vitamin D in such patients may be actually beneficial for the microvascular complications. And the cause for this may be that more studies are needed and better trials may be designed in the future, and we may try to find out whether vitamin D supplementation actually helps these patients. Whether the vitamin D dosage and duration can help patients of diabetes without these complications, that is, only can it affect the progression of diabetes, that part is again a very sketchy territory at present. So there are some concerns with vitamin D dosing. Many different studies have used different dosages, right from 400 units to very high dosages per day, and study durations have been variable. What we must remember is that in our practice, vitamin D supplementation should be individualized for each patient with an already established diagnosis of diabetes. In India, another issue is that because of rampant quackery and also use even by trained practitioners of very atypical doses of vitamin D and unmonitored and for a prolonged period or at very high doses, there is also a higher risk of intoxication. And in our geriatric ward, we often get every year practically we're getting patients who are presenting with hypercalcemia, altered sensorium, and finally they turn out to be cases of vitamin D intoxication because someone randomly has prescribed them a dose of say 60,000 units per day for long periods, which is not at all an indicated dose unless there is symptomatic hypocalcemia also in that patient. So we should always go for standard doses and should avoid intoxication in patients with vitamin D. So we should consider the initial serum vitamin D level. It is recommended that before initiating vitamin D, even if you get say elderly patients or diabetic patients who are having vague neuromuscular symptoms, lower limb pain or generalized bony pain or something like that, always go for a routine checkup, and vitamin D level estimation is quite cheap nowadays. You can go for a 25 hydroxy vitamin D basal level before you actually start supplementing. We should not blindly start supplementing, and we should use the standard dose. When there is a deficiency less than 20 nanogram per ml of vitamin D 25 hydroxy level, then we should supplement at the standard recommended dose, which is 60,000 units per week for not more than 8 weeks. And if after that the levels are corrected, then it's all right. If the levels are not corrected, you can give another 8-week course, but that too we usually refrain. And after that we put the patient on maintenance levels of vitamin D, which is around 1,000 units. You can give 800 to 1,000 units per day, which may be available in standard calcium supplements available in the market. So in conclusion, we can conclude that in patients like Hina, our example patient, where there is diabetes and there is coexistent vitamin D, we can give vitamin D supplementation because there is a proven deficiency. The case if there was no proven deficiency in this patient, it would be more confusing, because although vitamin D supplementation, although vitamin D deficiency has been linked to multiple micro and macrovascular complications in diabetes, the exact effect of supplementing vitamin D is still not clear in such patients. But if there is a proven deficiency in a diabetic patient, we can safely assume that giving vitamin D supplementation would be helping these patients. So these are the disclaimers. Thank you very much for your time. And we can take some questions if you have.
Hello, Dr. Shankar, am I audible to you?
Yes, sir.
So I would like to ask that how much vitamin D does the human body requires, and how can this vitamin D supplementation can be done? How much vitamin D does the human body needs?
Okay.
And how can this vitamin D supply be determined? How can we determine
whether we are getting adequate supply? Right?
Yeah. So how,
okay. Yeah, okay. So vitamin D requirement is specifically there in the pediatric population, which we unfortunately I don't deal with, and in the elderly population, or even in adults who are having proven vitamin D deficiency. So if you follow the simplified guidelines, the simplest guidelines for practitioners from other specialties is to follow the American Academy of Family Physicians. They give a very simplified guideline. If the patient is having deficiency of vitamin D, then you go for around 400 to 600 international units per day. Sorry, not proven deficiency. Those who are expected to be deficient may be having deficiency because of some reason. If you get a confirmed deficiency in some patient, adult patient or geriatric patient, then you go for a higher dose. If it is below 20 nanogram per ml, you always measure the 25 hydroxy vitamin D level first, and then only start supplementation. Don't go for blind supplementation. If it is less than 20, then you start with 60,000 units per week. The oral formulation is available. We always prefer the oral formulation, and you give it for not more than 8 weeks. After that, you do a repeat measurement. The AAFP recommends that if the levels are still low, we can go for another 8-week course. But usually the vitamin D level recovers. And after this, we can put the patient on a maintenance dose of 800 to 1000. A normal person gets most of the vitamin D from the sunlight exposure of the skin. So there is no need, there is no reason why a person should be vitamin D deficient, but the epidemiological studies are suggesting otherwise. So it is always better, especially in the geriatric population and in the pediatric population. I'll be talking more of the older adults only. If you see a proven case of vitamin D deficiency, you start the therapeutic supplementation. If you don't have that and you have a normal adult person, then 400 to 600 international units per day would be sufficing.
Dr. Sank.
Yes, sir. I have some comments.
Excellent presentation.
Thank you, sir.
And I think you were not very dogmatic, but on supplementation of vitamin D in prevention of microvascular and macrovascular complications associated with diabetes.
Yes.
Now, this vitamin D deficiency, which I have been reviewing for very long, I find it is one of the most contentious area which has evolved over the last 30 years. I don't know whether it is a activism of the pharma industry or whatever it is. I don't know. Because when we were students, or when you were a student, when we used to teach you, vitamin D deficiency, vitamin D measurements were not routinely available. And we used to go for vitamin D estimation, which was very infrequently available, in a group of patients who presented to us with hypocalcemia or normocalcemia with hypophosphatemia and raised alkaline phosphatase. If you remember that. So that was the dogma initially, that whenever you are getting hypo, or whether it is rickets or osteomalacia, what you should get is the patient should have hypocalcemia with, more importantly, hypophosphatemia with raised alkaline phosphatase. Now, when they started looking into vitamin D levels, I don't know, different groups have given different level of normalcy for vitamin D. Now the question is, another question came, what is the level of vitamin D which is good for? Is it a differential level for bone health, for cardiovascular health, and immunological health? These are the three areas where vitamin D has been very actively studied. One is for bone health. As for my concern is that I usually order a vitamin D estimation, which is still 2,500 rupees. It's not a cheap test to order. And that too, you do not know what is the level of reproducibility by a particular lab, given the different techniques they are using. Now, I only order in those patients where I suspect that, or I find that there is repeated hypocalcemia, or there is hypophosphatemia with muscle findings, or with raised alkaline phosphatase. Otherwise, everything is superfluous. You have different recommendations, different, and you don't know. Some people say that probably for bone health you need a smaller vitamin D. For immunological health, you need a higher level of vitamin D. And in a country where 70% people are vitamin D deficient in India, when you measure and the studies are there, in a sunshine country, will you call that as a abnormal or normal? So these are various areas Because, if the background noise is very high, it is likely to appear in various places. It is likely to associated with various things, whether it is cancer, whether it is infection, whether it is cardiovascular disease. If the background noise is so high, and if you raise the bar of vitamin D from 10 to 20, and then you make it 30, then you go on getting more and more associations. So I am of the belief that whenever I find that there is a symptomatic case, otherwise routine vitamin D supplementation, given the 60,000 doses and other, my point of view is I still have got a big question mark. And another thing which as an endocrinologist always bothers us is, if we rampantly introduce vitamin D, all the vitamin D indication, vitamin D intoxication is very uncommon. You need to have some mega doses of vitamin D to get vitamin D intoxication. But our concern is, in a country where hyperparathyroidism is so less, probably because of associated hypocalcemia. And because of the calcium intake and other things are less. And if we are giving a lot of vitamin D and calcium to these patients, are we making this normocalcemic hyperparathyroid overt? A lot of patients will get renal stones and other things if you rampantly, and these things have never been studied. And not a single interventional trial has shown that if you give vitamin D, it improves your cardiovascular health, or it improves. And look at it, though, everything started from America. And in America, if you find that supplementation of something is going to help you, and number needed to be treated is quite high, quite low, they routinely do it. But still they have not come up with one interventional trial. Why is that? All these things always make me feel that it is more of and maybe pharmaceutical companies have done business on billions of dollars.
Yes.
So that's one thing. It is something like Baba Ramdev speaking.
Right.
So that's my point of view.
Thank you very much, sir. And I'm really happy, sir, that you were around in this talk, because I wanted you to be around, and your insights are always really valuable, sir. And yes, and I would clarify here, sir, Arvind, sir, you asked this question. I was again not talking about routinely supplementing those who turn out to be vitamin D deficient. Even we don't do that in geriatric practice. We usually do the estimation when a patient with dementia comes to us for workup. As part of the initial laboratory assessment of dementia, we usually do that. And because it is one of the reversible causes, again, the evidence is sketchy, but we supplement it to normalcy before we can diagnose Alzheimer's or something like that. This we do for thyroid level also and B12 level also.
That's fine. That has been the standard clinical practice which we have been doing.
Yes. Second case where we do it is when elderly patients come with non-specific postural imbalances or tendency to fall, which is not fitting into any neurological condition or cardiovascular condition, or vague bony pains or lower limb muscle pains, which are maybe mimicking fibromyalgia-like conditions. But we find a low level of vitamin D in these patients. There we usually supplement, but again, not routinely. We perform it for every individual, trying to see if it is less than 20, and we'll supplement. So yes, I agree with sir. In different types of practice, and I think we can give the example of uric acid here. Sir would be better able to say here also, right, sir, that uric acid at one point, I think one study showed that anything above 1 is high and something, and everyone started targeting uric acid, especially in the cardiac specialties. And our classical teaching was, as long as it's asymptomatic hyperuricemia, you do not treat it. Sir, would you want to elaborate on that?
Right, definitely. And the another thing is that uric acid is considered to be a very good antioxidant. Right. And certain level of uric acid needs to be there in the body. Another dogma which prevails in the market is, if the patient has got uric acid hyperuricemia, stop all dairy products. In fact, that is ridiculous. In fact, dairy products are one which bring down uric acid. So these are some unusual dogmas which prevail in the in medical community. Doodh band kar do, ye band kar do. The dairy products are the only one which will bring down uric acid. Otherwise, but I don't know why do they stop it. So once it goes on like that. So uric acid is good. It's not bad. But anything which is beyond a particular particular level is abnormal, and where it starts crystallizing or doing something else, it's fine.
Right.
Otherwise, it need not to be addressed.
Right.
And you can imagine how much drug we'll be adding if we go on doing like this. The patient will be full of not eating; he will be taking only drugs.
Absolutely. Absolutely, sir. I think in older practice, our aim is always to cut down on medicines, and we try to do that. Any further questions from anyone?
Yes, sir. I wanted to ask one question. Sir, how safe is supplementing vitamin D in cardiac patients?
Vitamin D general supplementation is not known to cause cardiotoxic effect of any sort. If you are giving it as a standard dose, to my knowledge, there is no evidence that it is risky for cardiac patients. Would sir want to comment something on that, Professor Rai, sir?
No issues. Vitamin D you supplement. What I'm saying is whether it is needed or not.
Yes.
Because I'm not spending anything
Yes.
from my pocket.
It is not per se a toxic thing unless you overdo it. And a very common thing we notice is people have been recommended vitamin D at 60,000 units per day for a long period without any reason. And even if it is in a deficient state, this is not the recommended dose of supplementation. Only when there is symptomatic hypocalcemia, then you can use higher dose for a short period. Otherwise, we always cut it down to 60,000 units per week, maximum 8 weeks, not more than that. So this is what we usually do.
So there's one more question in the from the viewers link. Sir, this is probably not from this topic, but somewhat related to it. Uh, People are using zinc in diabetes patients. What is the role of zinc in diabetic patients?
Okay, so I'll give my view first. Routine supplementation of any micronutrient doesn't have a proven value in majority of the conditions. There was a fad of chromium or something otherwise supplementations, and all these things come up. They are not of any value in most patients. So I would want some expert opinion because this is a diabetes related question. Again, Professor Rai, sir, you may comment on this also.
There is no role of routinely supplementing. I think if the person is eating normally, he has got adequate things. Why do you need to supplement it? And I can tell you at another vein that the lesser the drug, better is the compliance. We are more interested in glycemia control. We are more interested in hypertension control. We are more interested in which are like really proven benefit. Statin to control dyslipidemia. And if we go on adding the drug, the patient will think that vitamin D is more important, zinc is more important, the picosul is more important. And they will, so lesser the drug, better is the compliance in a long-term therapy. So if you go on adding, so you should be very cautious in doing that. And that is why there was a concept of polypill, because the more the drug, lesser is the compliance. So why not combine everything in one and give it to the patient if it is needed? So why do you want to burden the patient with so many drugs unless it is definitely needed?
Thank you, Dr. Chakravarti. Now, Dr. Arvind will take over and proceed to the next session. It was a very informative session on vitamin D supplementation.
Okay.
Dr. Arvind, please proceed.
Thank you, everyone.
Thank you, Dr. Shankar, Raisa, for a nice conversation. I would like to invite my respectable head of the department, Professor Sanjay Kumar. He will just give his talk on unlocking the potential of first-line therapy in hypertension. Professor Sanjay Kumar is done his MBBS, MS, diplomat in National Board and MCH in CTVS. Currently working at head of the Department of Cardiovascular and Thoracic Surgery, Institute of Medical Sciences, BHU. He did his MBBS from Chipmo Pondicherry and post-graduation MS and MCH from Christian Medical College, Vellore. He did his fellowship FRCS from all three Royal Colleges of Surgeon, Edinburgh, England and Ireland. He had worked in London, Oxford, Birmingham in UK and Yale University in USA. He had special interest in mechanical circulatory assistance and heart transplantation with more than 135 articles internationally. He owns a fellowship or membership at FRCS ED and FRCS England and FRCS. Now, over to Sanjay sir for the next presentation.
Good evening, everybody. Thanks, Arvind, for your introduction. And I just want to. Screen is not coming. Can you see the screen now? Yeah. It's sharing now. Can you see that? Yeah. Are you able to see? अरविंद तुम्हारा भी शेयर हो रहा है Is it okay? Okay. Is it sharing now?
Yes, sir.
Okay. All right. All right. Okay. So sorry for the inconvenience, guys. So Amit has given me a topic which is more like a, cardiologist topic. However, based on our clinical experience, we will share the all information that is available from the literature. The topic is about the unlocking the potential of the first line combination therapy in the patients with the hypertension. So in this talk, I will just cover what is hypertensive, new in the hypertension management. What are the newer guidelines and what is the advocacy. Especially my focus will be on the ARB and calcium channel blockers based on the literature that is available in the current era. So why amongst the ARBs, why azilsartan and why clonidipine are preferred? That will be the focus of the talk as well. So hypertension, based on the literature, it affects about 40% of the population, industrialized areas. It is associated with the additional risk factor in over 80% of the patients. It is a comorbid condition in majority of the patients who suffered with cardiac illness. It is a worldwide problem, and it contributes to a significant proportion of death related with the cardiovascular illness. So what are the things that have changed recently in the management of hypertension? So based on the information from the European Society of Cardiology, Munich Conference 2018, still we are looking for universal ideal drug, universal BP target, the things which are actually what kind of combination should be used for different group of the patients or different specific patients with a specific risk factor. And what is the precision target of the blood pressure, and what is the combination therapy, which is the preferred choice in the selected subgroups. So these are the things that is now actually evolving in this current era. So it is basically we all can understand that what will be the ideal drug. So ideal drug will be the drug which can be based on the given on the evidence base, which actually is lower. Means if you have a drug which is like gives you a control over 24 hours, single drug, that may be the one which may be the ideal drug. It should be affordable, cost effective, because logistic comes into play, especially in the patients who are of low socioeconomic places and patients who are patients of India. So treatment should be well tolerated. There should not be side effects, and benefit of these use of this medication to the population, it should be applied. So if you really see the how we initiate the blood pressure this treatment based on the various grades of the blood pressure, the treatment protocol is actually initiated. So in the lifestyle advice is actually considered in all these patients. And if you have a high normal blood pressure, again, you start with the various drug combination. Then if the blood pressure goes in the category of grade 1, then immediate drug treatment, and especially in the patients who have the high risk or associated cardiovascular disease or renal disease. If the patient they have a grade 2 or grade 3, then immediate drug treatment is considered for all these patients. So the principle of the blood pressure, just one second. Principle of blood pressure treatment target range. If you try to keep the blood pressure in the range of 120 to 140, this is the optimum target range, and these are that offers the maximum benefit to this patient. And if you have patients who have more than 140, there is an insufficient risk reduction. If you try to achieve less than 120, the benefits are uncertain, and in these patients may have risk of harm. So uniform drug treatment strategy for the hypertension. It is important that we recognize that most people who need that one drug to control the blood pressure, that initiate the treatment with two drugs in majority of these patients. And the strategy is to tackle the treatment criteria, which is moving beyond the monotherapy, because though the monotherapy may be attractive, but it is in order to achieve the better control, it is always better to start with the multi-drug combination. So two drug initiation is the very common practice now. Recognition that the treatment adherence is a major obstacle to the patient. The compliance is the poor if you try to use multiple drugs. So use 2 or 3 drugs in a single pill. That may be something which can help you with the patient compliance of taking medication. Recognition that evidence-based support that the three major group of drugs which are commonly used are the RAS blockers, calcium channel blocker, and thiazide group of diuretics. So BP lowering agents, if you see the list of it, there these are the list we have available. So drug treatment of the patients with the hypertension. Now, what we do actually in established patients with the hypertension, which is not controlled with lifestyle measures, then drug treatment threshold is in order to bring down their blood pressure. And now there is actually European optimum for patient with less than 65 years of age, 130 and over 80, and more than 65 years of age is 140 over 90. Essential, it is important to reduce the diastolic by 20 and systolic by 10. It's always beneficial. So optimum treatment, again, up titrating the target, and in order to achieve the various combination and adding spironolactone in those cases which may not respond, there that may be the initial plan of strategy. Use the diuretic, thiazide-like diuretic preferentially. That is one of the things which has stood over the time. And the ideal agent which are available would focus on the blood pressure lowering, which is, as I said, less than 20 and over 10 for the systolic and diastolic lowering. Now, strategy for uncomplicated hypertension. So initial therapy is using a dual combination therapy, and you can use as a combination single pill, ACE inhibitors or ARB, along with calcium channel blocker or diuretic. This is considered a monotherapy in lower risk group of patients. Step 2 is using the triple drug combination, which may be in a single pill, ACE inhibitors or ARB with calcium channel blocker along with diuretic. And step 3 is the patients who have a resistant hypertension. So in those cases, you can use a triple drug combination, which may be in 1 or 2 pill, and along with that, you consider adding spironolactone for these patients, 25 or 50 milligram OD. This is considered cases which may need further workup and also a specialist center care. Beta blockers may be considered at any stage in these patients, especially the patients who have other risk factors. If they're the patients who are in atrial fibrillation, the younger woman or who are planning pregnancy, these are patients where adding beta blockers may be considered. Drug treatment strategy again with the hypertension along with the coronary artery disease. So these are the patients, again, you look at that combination is more or less same. And for the patient who are low risk category and patients who are resistant category. So then if you come to the patients who have hypertension with CKD, so these are the patients where you will be careful using the diuretic, and there, when you use the diuretic as a single pill, initial dual combination therapy, ACE inhibitor, ARB along with the calcium channel blocker, plus diuretic, which may be a loop diuretic, it may be considered. You can consider beta blocker at any stage, again, as per the associated risk if the patient has in heart failure, angina, post-MI, atrial fibrillation, or younger patients. Similarly, this step 2 and step 3, this line of management is there for the patient who are in this category of hypertension with CKD. Now, this guideline, there is an increasing role of ARB in recent era, and why ARB is being preferred are the patients. It helps in the patient who have heart failure, the patient who have post-MI, diabetic nephropathy, proteinuria, microalbuminuria incidence is less. Patient who have a left ventricular hypertrophy, it helps in reversing the remodeling process of the ventricle. And patient with atrial fibrillation, metabolic syndrome, and if somebody where you have tried ACE inhibitor and they develop refractory cough, dry cough, then in those cases, ARB will be helpful. The RAS blocker is a foundation now, actually using ARB or ACE inhibitors. If you look at the various targets which we compare for ARB and ACE inhibitors, BP control along with other associated comorbidities like secondary MI prevention and chronic systolic heart failure, type 1 diabetes. Across the board, ARB does have edge over ACE inhibitors, as you can see from this chart. So now, since we have already seen from the literature that ARB may be something which one should focus as a RAS inhibitor medication of choice. Now, the combination therapy, whether we should try combination therapy or just monotherapy for initial treatment of hypertension, there are pros and cons from the literature, which I'll just show. So the majority of the drug cases, the incremental effect on the systolic blood pressure lowering by doubling the dose of monotherapy is 20%, and that achieved by adding a drug from another class. So it's always the combination, the two drug combination from a different class that gives you a better control of systolic blood pressure than upping up the dose of one particular monotherapy. Fixed drug combination, there are pros and cons again, like single pill fixed drug combination. It can help you getting a better patient compliance. However, and there are some benefits as well. So if you really see that there may be improved BP control, normalization, increased compliance, improved persistence, it reduces the total and cardiovascular related hospitalization, which is a major burden for this kind of patient with a heart failure who have a repeated admission. Now let's look at this synergistic combination of calcium channel blocker with ARB. So if you really see how calcium channel blocker ARB, they work in isolation and how the synergistic action can be beneficial. So this chart has clearly shown that benefits of both CCB and ARB if it is working alone. And if they are in combination, that there is a synergistic blood pressure reduction, and which obviously helps you achieve a better control of blood pressure. So tolerability of how these drugs are tolerated. ARB, if you look at that across the board, that is the most well-tolerated class of medication, antihypertensive drug. So whether in isolation or in combination, ARB always has been found to be better. This is one of the Italian study where they found that what percent of the patient that discontinued the taking medication during their course of management of hypertension. So ARB ones where they have the minimum number of patients discontinuing medication. So the patient is sticking to this kind of regime where the maximum with the ARB alone or in combination. What does FDA they feel about ARB? So they, according to them, they are well tolerated. They have a placebo-like effect. It should be started at the maximal approved dose. And but now the question is, all the ARBs are they all same, or did one has better, one has is over the other? So FDA says that what exactly you're trying to achieve is the decrease in the blood pressure. So the drop in the systolic blood pressure, that is the one which is rather than using a particular type of antihypertensive, but that is largely responsible for the cardiovascular benefit. So the greater antihypertensive benefit amongst the sartans are achieved with the agilsart, and certainly it will serve to justify clinical interest in recently approved ARB. So if you really see that ARB, why this agilsartan has edge over the other, I will actually go through in this subsequent slide all this information that is available. So response rate with the ARB, if it is used as a monotherapy. So different kind of sartans, if you really see, as I said, that the max dose is allowed, approved for these medications. So agilsartan 80 milligram, agilsartan of 80 milligram, you can see the comparison. It's almost like a double of the response rate as you achieve with the patient who are on agilsartan. So what are the other distinguishing feature of agilsartan medoxamil? So first, as actually it should be started at the maximal dose, as I have also shown in the previous slide as per the FDA approval. And first, again, this is the one actually it helps you achieving a 24-hour blood pressure control. And it can be combined with the chlorothalidone and not with the hydrochlorothiazide. So how agilsartan compares with the other ARBs? So they are more effective in lowering the blood pressure. That's the potent one, and which achieves the blood pressure control across 24 hours. So it is actually the reason why it is because it's a highly lipophilic, and it has a longer half-life compared to the other ARBs. It also helps lowering the nocturnal blood pressure, which may be a problem with other BP control regime, and it has almost the same side effect if you really want to see compare with the other ARBs. So what are the main difference that says that it's a chemical structure, that agilsartan is a tetrazole ring with oxadiazole ring, and that having a maximum the long half-life, because it is less acidic, more lipophilic. So agilsartan, it gives you a better control systolic as well as diastolic blood pressure reduction. Clinical diastolic blood pressure, it may be 2.6 millimeter greater reduction compared to other agilsartan. And if you really see 24-hour, the mean will be almost like a 2.1 millimeter greater reduction compared to the other sartans. It has got a systolic blood pressure reduction. It's very well compared to olmesartan or valsartan. Agilsartan patients who are on hemodialysis, so it has been found that they have a better, again, systolic and diastolic blood pressure reduction. The patient who are a part of the metabolic syndrome, like a pre-diabetic, diabetic, or salt-sensitive patients, so there you will again find that it has got a cardioprotective action as well, and it gives you a better control of blood pressure. It has got a certainly beneficial compared to the other sartan. So now it does have a pleiotropic action, just like any other sartan. However, predominantly so because it helps in stabilizing the atherosclerotic plaque. It reverses the process of the cardiac remodeling that happens with these patients of cardiac failure and hypertensive patients. It has anti-inflammatory action, and also it has the it is healthy for the vascular structure as well, because it reverses the remodeling process of the blood vessels. Agilsartan medoxamil in the various clinical trials that has clearly shown that primary outcome in these patients were achieving a 24-hour blood control. So that they found that is the one which they were able to achieve compared to the other sartans. So that is certainly one of the actually a target, which is finding a ideal antihypertensive drug. So to conclude, we have it's a newly diagnosed hypertensive patients. They are actually lesser now, but there are frequent clinical decisions to choose either the ACE inhibitors or ARB. So you'll have a practice-based evidence that clearly shows that ARB have edge over ACE inhibitors, and also amongst the ARB, azilsartan is the one which should be a preferred medication based on this information what we have. So I will just go to the other slide. So that azilsartan, it is recognized as the gold standard treatment for hypertension. So and it is actually, people have been looking for the patients who have agents which can help in the patients who have a resistant hypertension as well. So based on the clinical profile, it is azilsartan is the current clinical gold standard in the drug comparator model. Azilsartan, it was actually it was one of the medications which was launched in 2011. It has efficacy benefits over current therapy. It is demonstrated superiority in the reducing the blood pressure over valsartan and ramphil in the phase 3 clinical trial. So it is over across 2015 and 2020. We do not expect any therapy in the development to replace azilsartan as the clinical gold standard. That was the one of the conclusions from the this data. So now the place in the therapy as an antihypertensive medication. So it is a new angiotensin receptor blocker, and BP control and response rate for the drug is highest compared to the other sartan, and it may be useful in the treatment option to enhance the blood pressure lowering the patient whom dual antihypertensive therapy with a generic ACE inhibitor or ARB plus calcium channel blocker or diuretic has not reduced the blood pressure to the desired level before trying triple therapy with the other medication. Now let's come to this calcium channel blocker, because we were thinking that which RAS, so we concluded that azilsartan probably is a better of the lot. And now calcium channel blocker in the hypertension. It is time to look beyond the BP reduction. That's the caption, and that shows that calcium channel blocker and cardiovascular protection. In the absence of albuminuria with a preserved GFR, a calcium channel blocker can be contemplated as the first step therapy and seems to preserve GFR in adequate manner. In presence of diminished GFR without albuminuria, a calcium channel blocker can be used as a first step therapy. Now, combination therapy in addition to the ACE inhibitor or ARB may be one of the combinations that can be tried. So calcium channel antagonist, it has a major role in the treatment of patients with the hypertension and coronary artery disease. That was the conclusion that was drawn way back in 1999. So there are none of the widely trumpeted dangers from dihydropyridine calcium channel blockers. So that was the comment by Kaplan in 2003. Drug treatment of hypertension. Recent investigation have suggested that in addition to their ability to vasodilate, these they also have a pleiotropic effect, and it helps in the endothelial function, by which it improves the nitric oxide level and oxidative stress on these vessels, and it helps in the health of this vascular endothelium as well. Calcium channel blockers, they have a strong position in guideline. So they are recommended across many patient characteristics. So both calcium channel blocker along with ARB or CCB along with ACE inhibitors are recommended combination for the blood pressure control. And these combination are considered superior to ACE inhibitor or diuretic or calcium channel blocker with diuretic combination in higher population. So calcium channel blocker are actually, if you really see the vasodilator potency of calcium channel blocker, it varies according to their subclass. Now we are trying to look at which may be a amongst the various generation of the calcium channel blocker, which may be the one which one would consider using in the current based on the current evidence. So there are two types. Actually, they're broadly classified as L type and N type. So that 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 chart clearly compares that what effect it has on the contractility of the heart rate, and also sympathetic nervous system. So they are the one which helps you decide which are the one we would consider using. Conventional calcium channel blocker, which is the earlier generation of the calcium channel blocker, it leads to the reflex tachycardia. And these patients, they do have complain of the pedal edema, and there may be increased evidence of proteinuria in these patients. So now we are actually looking for these patients where we can get away with these complications. So which are the group of now calcium channel blocker which may help? So the newer generation of the calcium channel blocker, cilindipine. If you really look at its pharmacology, it is an L-type calcium channel blocker. And what it blocks amlodipine, how it compares with this N-type calcium channel blockers. So there, if you really see them, how it leads to on the blood vessels, it leads to the vasodilation. It also helps in this patient with the beta-1 adrenaline receptor with the on the heart and kidney. It improves the blood flow and also renin secretion in the kidney. So that's how it really, this N-type, they have, you can see that how it fares over the L-type, your L-type. So effect of the L and N-type of calcium channel antagonist, cilindipine, on morning blood pressure control. So that is one of the issue which actually has been raised in the various calcium channel blocker, and it has been found that cilindipine has a greater effect on the morning hypertension control, and it causes without causing any leg edema, or it can be when administered at the bedtime, unlike the earlier generation of the calcium channel blocker. The inhibitory action and resulting vasodilatation of the arteries and vein by the L and N-type calcium channel blockers, cilindipine, are clinically useful feature for treating the patient with the antihypertensive patients. Now, how we actually look at this amlodipine versus cilindipine. So both the drugs are significantly, it helps in reducing the 24-hour systolic blood pressure and diastolic pressure. However, there is, if you really want to see the effect of cilindipine, it's like 88% more reduction in the systolic blood pressure in cilindipine group compared to the amlodipine group. So it does have a cardioprotective effect in that run. N-type calcium channel blockade by cilindipine may not cause reflex tachycardia. That is the advantage. And it may be useful for the patient with the hypertension. Now, looking at the effect of the proteinuria, certainly this cilindipine it has a less propensity to have that issue, like unlike amlodipine. So now, Indian study that was done in way back in 2014, it showed that cilindipine offers greater reduction of the blood pressure and prevents the ankle edema in the patients with the hypertension management. This is always actually, this was one of the subgroup of the patient which were tried in Amritsar, Punjab, and they had about, they compared cilindipine versus. What about the patients with the hypertension and diabetes? So there are studies which have shown that in these patients, the urinary albumin excretion is far less compared to those patients who are on amlodipine. In cilindipine group, again, there is a the urine. So yeah, it did not show any difference in 12 weeks or 24 weeks of treatment amlodipine. Now this if you look at this newer generation of this cilindipine calcium channel blocker cilindipine, it inhibits both L and N type of channels. So unlike the earlier ones, which was predominantly L type. So it is effective as traditional calcium channel blocker for BP reduction. At the same time, what was the problem with the earlier generation of the traditional CCB? That is not there. So there is a reduction in the proteinuria, lesser risk of ankle edema, and better improvement in the cardiac function and uric acid level. So advanced generation of antihypertensive. So if you really see that what are the things which one would like to achieve, it's slower onset. It should have a longer duration of action. What we are really looking for is the single drug which may really help rather than having multiple drugs. Then it should also suppress the sympathetic overactivity. So reflex tachycardia should not be there. Metabolically, it should be neutral. So the patient who are having dyslipidemia or diabetic, or even the patient who have a renal problem, that should not have any additional side effect on that. And if they have an anti-inflammatory and pleiotropic effect, so that really helps in additional benefit of reversing the remodeling process on the heart as well as the vessels. So now let's come to this combination, which obviously is available now. And azilsartan, medoxamil 40 milligram with cilindipine 10 milligram. This combination, as we have come to a conclusion that among the sartan, azilsartan is a preferred, should be a preferred one. And if you want to choose the newer generation of the calcium channel blocker cilindipine, now let's see this combination, how it fares in the management of the blood pressure control. So now you have, you're trying to see whether you really think that it is the best of both the worlds. So cilindipine, actually, it is an Allen N-type, both calcium channel blocker. So it reduces the norepinephrine release. So vasoconstriction will less, reflex tachycardia will not be there. Patient will have increased renal blood flow, proteinuria will be less, renal secretion will be decreased. So now, when you see the azilsartan, it decreases the vasoconstriction. So and also aldosterone secretion, catecholamine release. So that decreases the whole effect is decreasing the blood pressure. If you combine these two, then certainly it has a synergistic effect, and you are trying to achieve better control of the blood pressure with lesser side effect. And now this cilindipine to ARB monotherapy significantly reduces the blood pressure. So if just adding this one drug to this ARB cilindipine, that starts giving you the benefit which you are really looking for, and that's a significant improvement in the drop in the systolic and diastolic blood pressure. There is significant reduction in the baseline systolic blood pressure and diastolic pressure once you add cilindipine to the ARB monotherapy. Now this you will be able to achieve the blood pressure goals in most of the patients when you use this combination, the cilindipine along with the ARB. So blood pressure goals, like as now the guidelines are trying to suggest. So if you really see those subgroup of patients, you will see that the how we really fare in the controlling the blood pressure. So it is about 31.39% of the patient who may have total systolic blood pressure, is total blood pressure control, which you will achieve. And changing the heart rate after adding cilindipine to the ARB monotherapy, it has got a significantly negative correlation. So it, in fact, the reflex tachycardia, that's a problem with the early generation of the calcium channel blockers, will not be there. So azilsartan now, if you really see that, it is the 8th ARB to be approved for the treatment of hypertension. It gives you a 24-hour control of the blood pressure. It is more effective than other sartans. If you combine it with the calcium channel blocker, it is certainly gives you advantage of being more effective in lowering the systolic blood pressure. It reduces the other side effect associated with the calcium channel blocker. And combination with if you want to combine with the thiazide like diuretic chlorthalidone, further helps you in controlling the pressure in the patient who may be resistant to this combination. It is a calcium. It's cilindipine. It is a 4-channel, means 4th generation. This is a newer generation of the calcium channel blocker. It is vasoselective. It's healthy for the vessels, and it blocks the N-type channel along with the L-type. So you have the benefit of both that you can achieve. So there is a lesser tachycardia, fetal edema. It has cardioprotective effect, renoprotective effect, neuroprotective effect, and also it has been found that it improves the insulin resistance. So that means you patient who are diabetic, you do have an additional, or if they are pre-diabetic, you have an additional advantage of using this calcium channel blocker. So with this, I would rest my talk, and I have used, actually, I must confess, I've used this combination, and I've used it on some of my close relatives as well. And I'm very happy with that, because the number of additional medication that you really need to top up in the evening to control the night blood pressure or morning rise of the blood pressure, that is not there, because it gives you a really 24-hour control of the blood pressure. So now it's open for any question. If you have any, just shoot it away.
Hello. Hi, sir. Such a nice presentation. I'd like to ask one question: that which ARB is superior in patient in all sensitive cases?
Arvind?
Yeah, sir, am I audible? Am I audible, sir?
I
Am I
can't
audible,
hear.
sir?
Is anybody saying? Huh? Please answer the question. Hello? You can unmute yourself, Arvind.
So am I audible?
Now you are audible. I can hear you. Yeah. All right.
I would like to ask that which ARB is superior in salt sensitive case?
Sorry, say it again.
Which ARB is superior in salt sensitive cases?
Well, having said that, I would say that valsartan was the one which was considered superior earlier. But with this agilsartan, I must say that this may have, I don't have that precise information on that, but I would say that that may have an edge over other sartans in that context as well.
And so, how Elisartan and cilindipine combination is superior in cardiac and diabetic patients?
Yeah, as I told you that the cardiac benefit, what you have is that control of the systolic and diastolic pressure. Along with that, its pleiotropic effect, which is both on heart and as well as in the vessels. So it reverses the helps the patient with the cardiac hypertrophy, and also endothelial function improves. So they are the one that helps you with the better benefit cardioprotective effect. Now you're talking about the diabetes. So as I said, one of those slide where this combination actually it helps the patient with the insulin resistance as well. So the patient who are pre-diabetic or patient who have issues with the insulin resistance, so this combination may benefit them too.
Thank you so much, sir. Now I would like to hand over the session to Dr. Amit Srivastava.
Good evening, everybody. Am I audible?
Yes, you are audible.
Yes, sir.
Yes. So, our next session for today is a case based discussion on heart failure. I'll be moderating this session, and the speakers will be my esteemed senior Dr. Alok Kumar Singh. He is DM Cardio, MBBS and MD from IMS BHU Varanasi, and DM Cardio from KGMC Lucknow 2010. He is IAFS CIA from USA, AICT Korea. He is founder, editor-in-chief, Heart India Journal by Walter. He has published almost 8 publications with 30 issues till 2020. He is founder, editor-in-chief, Medicine India first issue expected in 2021. He is executive editor, Journal of Cardiovascular Disease and Research, associate editor, Journal of Clinical Diagnostic and Research. He is editorial board member of the Journal of Advanced Research in Medical Sciences and Technology and founder of the Heart India Conclave. He has experience of performing more than 5,000 coronary intervention and device implantations, experience of performing more than 50,000 echocardiography, TE and stress echos. He has more than 70 publications in various international and national journals, co-investigator for various clinical trials including SHIFT trial and Paradigm HF trial. He is advisory board member of Novartis, Abbott, Cipla, Lupin, etc. He is regular guest speaker on various national and state level conferences like National Epicon, CSI, and state chapter conferences. He is member of ACC, CSI, ESC, and API Varanasi chapter.
Hi, Alok.
Hi, boss.
Yes.
Welcome, man.
Am I audible, boss?
You are audible.
Yes. Our next speaker is Dr. Ashutosh Mishra, and he is my fellow colleague. And he is MBBS, MD Medicine from IMS BHU, Fellowship in Diabetes, DFID, CMC Vellore, ex HSSR Endocrinology from SGPGI Lucknow. He possesses a professional experience of 19 years as endocrinologist and diabetologist. Currently consultant endocrinologist and diabetologist, Panacea Hospital, Varanasi. He is head Diabetic Care Organization, Varanasi. He is assistant professor of Panacea Institute of Interdisciplinary Research Education at Varanasi. He is founder and national secretary, Cardiabicon National Conference, and deputy editor of Cardiabizen. He is faculty Global Alliance of Medical Education, GAME, and National Coordinator Cardio Diabetes Educational Program, CDSME. He is ex-assistant professor medicine, SRMS, IMS Bareilly, and member European Society of Endocrinology. Welcome, Dr. Ashutosh.
Thank you, Dr. Amit.
Dr. Ashutosh, are you here?
Yes, yes. Thanks for
Okay.
your presentation and
We have two expert panelists, Dr. Vineet Agrawal. He is MBBS from IMS BHU 1991 batch and MD Medicine from IMS BHU. He is DM Cardiology from GSVM Medical College Kanpur, currently working as Senior Consultant Cardiology at Galaxy Hospital, Varanasi. Dr. Agrawal is member of the CSI India ESC API Varanasi. He is speaker in various national and regional scientific forums. And our next expert panelist is Dr. Suyash Tripathi. He is DM Cardiology, Assistant Professor, Department of Cardiology, IMS BHU Varanasi. He is MBBS from AIMS Delhi and MD Medicine from KGMU Lucknow. He is DM Cardiology from Suchitra Institute Trivandrum, and his key area of interest is complex PCI, pacing devices, and EP studies. He is managing coronary intervention, pediatric interventions, and pulmonary valvoplasties. He is member of CSI, ACC, and API. He has been a speaker of many national forums. Welcome all the speakers, panelists, and all our viewers. So we will start with the presentation right now, which is a case-based discussion on heart failure. Next slide, please. Yes. So there is a clinical correlation between diabetes and heart failure. If the patient is diabetic, hyperglycemic, insulin resistance, and hyperinsulinemia is present, there is ASCVD, hypertension, metabolic disturbances, there is disturbed cellular function, structural alteration, cardiac autonomic neuropathies. He is there are neurohormonal activations like RAS activation, which causes fibrosis and cardiomyocyte hypertrophy. All this ASCVD results in ischemic cardiomyopathy, hypertension results in hypertensive cardiomyopathy, and all the other things result in diabetic cardiomyopathy and thus causing the heart failure. The patient with diabetes have more than twofold risk of developing heart failure. So in diabetic patients, there are independent risk factors of the heart failure. And there is almost 45% of the patients who are hospitalized for heart failure with diabetes, and men are 2 times more at risk, and female patients are 5 times more at risk. There is 2 times risk of developing heart failure in patients with diabetes mellitus. The prevalence of heart failure in diabetic population is 4 times higher than in general population. So now the case scenario which we'll present here is Mr. Akshay, who is a 65 years old gentleman, retired government officer, has diabetes since 7 years, and he has heart failure with reduced ejection fraction since 3 years. His current therapies for diabetes is metformin and vildagliptin. For heart failure with reduced ejection fraction, and MRA. However, recently the patient started complaining of difficulty in breathing, tiredness, and swelling over the feet. I like more walks with my colleagues. Since last week, I'm skipping my morning walk and facing difficulty in exercising too. And on clinical examination, investigation, blood pressure of the patient was 120/80, fasting blood sugar was 120. Echocardiography showed the left ventricular ejection fraction of 24%. Serum creatinine was 1.13. NT-proBNP was 1642, which was significantly higher, and HbA1c levels was 7. Based on the clinical examination, current therapy with ACE inhibitor or ARB is not showing clinical improvement in Akshay. So, with this background, I would like to ask the questions from my speakers and panelists. Do you feel that Akshay is at increased risk of patient and action? The next question will be to the cardiologist. With increased risk of mortality, how does ARNI or sacubitril valsartan impact outcome in patients with diabetes and heart failure with reduced ejection fraction? Does NT-proBNP plays a major role in prognosis of the patient with diabetes and heart failure with reduced ejection fraction? Next question will be to the endocrinologist. What is the impact of sacubitril valsartan on glycemic control and use of insulin in patients with diabetes and heart failure with reduced ejection fraction? So all these questions we will be asking to our panelists. And my first question to Dr. Alok will be, do you feel that Akshay is at increased risk of mortality? Alok, please.
think I should say, as rightly said, what is the prevalence of diabetes in heart failure? And if you see the all landmark trial of heart failure in chronic heart failure patient from SALT 1991 to Emperor reduced in 2020, you can see in SALT 1991, around 18% of heart failure patients were diabetic. And whereas in Emperor reduced, it was around 27% were diabetic. And some trial like DAPA-HF, it was around 51%. So approximately 40%, 30 to 40% of your heart failure population is diabetic. Next. So if you see, I think, Amit, I will like to take the control. I will present from my side.
Is it possible?
Yeah, I am having the slides, so I will like to present. I think that will be better.
Okay. So you start. I'll start
you start
screen sharing from my side. You start sharing.
Okay.
Yes, please.
Heart failure and diabetes prevalence. If you see from the landmark trial from SALT 1991 to the Emperor reduced, the prevalence of diabetes is around 25 to 50%. So approximately 1/3 of the heart failure patient with diabetes, and there is a 64% increase in the risk of CV death and heart failure hospitalization in patients with diabetes and HFrEF, and 54% increased risk of cardiac death in the diabetes and heart failure patients. So the next question to the panel, what is the treatment approach in patient with diabetes and HFrEF? And what should be the approach in managing the patient with HFrEF and diabetes like Akshay? Whether we should continue to ACE and ARB, switch to ARNI and switch to SGLT2 inhibitors. And option A, continue ACE and ARB. And if you see, in spite of the mortality in HFrEF remains high, despite the use of conventional therapy like ACE inhibitor, beta blocker, MRA and ARBs. So still, with the use of the drug, 5-year mortality in the tune of 50%. So still we need a drug in spite of ACE inhibitor, beta blocker and MRA to be added in this population to reduce the mortality. And severe heart failure lead to better therapy in patient with diabetes and HFrEF. Several heart failure patient therapy like beta blocker and diuretic might aggravate dysglycemia, but still the benefits of beta blocker is there irrespective of the diabetic status. It has been demonstrated in multiple randomized trials. Hence, new therapies are needed to improve the survival in patients with diabetes and HFrEF. And here, from ACE inhibitor to switching to ARNI is a better option. Sequetril and valsartan is now recommended as the first-line therapy for all HFrEF patients for renin-angiotensin system inhibitor over ACE inhibitor and ARB for all HFrEF patients. So now the direct to ARNI approach is recommended because a lot of data after the publication of Paradigm HF have come into our domain, and sequetril valsartan now so superiority over ACE and ARB in HFrEF patients. ARNI has an expanded role focused on the optimizing therapy for superior benefit in de novo patients, rapid improvement in patient reported outcome measures, symptoms, physical functioning, quality of life, and Also, it has the cardiac reverse remodeling effect independent of the background therapy on over an ARB, because sacubital hernia is a therapy where we combined neprilysin inhibitor with the valsartan. So, over and above, independent reverse remodeling have been observed with the hernia independent of the ARB effect. Next option is switch to SGLT2 inhibitor. SGLT2 inhibitor is an add-on therapy. Recent ACC 2021 consensus recommends, and yesterday European Society of Cardiology heart failure guideline have been released, and I was going through. In that also they have recommended SGLT2 inhibitor should be added as a part of HFrEF, and who are already on ARNI beta blocker and aldosterone antagonist. Now SGLT2 inhibitor is a standard heart failure therapy, proven. Now the data of Emperor Preserved have came again. It has shown beneficial results. So like beta blocker, ARNI and aldosterone antagonist, now SGLT2 inhibitor is one of the first line drug which should be added in all heart failure patients as early as possible. So in these patients, SGLT2 inhibitor should be initiated as an add-on therapy after the preferred first line therapy like ARNI, beta blocker and MRAs. And next question to me was, with increasing risk of mortality, how does sacubitril valsartan impact outcome in patients with diabetes and HFrEF? And sacubitril valsartan improves the clinical outcome in patients with diabetes and HFrEF. There is a 20% reduction in cardiovascular death, heart failure hospitalization with sacubitril valsartan compared to enalapril, irrespective of the glycemic status. So you can see, irrespective of diabetic status, whether diabetes was diagnosed or not undiagnosed, or pre-diabetes and normoglycemia, overall advantage of sacubitril valsartan remains there over and above the enalapril. And again, sacubitril valsartan improves the survival in patients with diabetes and HFrEF. Sacubitril valsartan keeps patients with diabetes and HFrEF out of hospital. So risk of heart failure hospitalization is also reduced in this population, irrespective of the diabetic status. I think next question to the endocrinologist, I think Asutosh, you will like to take. Does NT-proBNP play a major role in prognosis of patients with diabetes and HFrEF? I think you share. I think at your time you share, and my time I will share. That will be better.
Okay. Okay.
I think you can take all your questions. Then remaining question I will take. Remaining cardiac related questions. That will be better.
Okay. My screen is visible.
Yes, yes.
And the question which I am supposed to answer is, does NT-proBNP plays a major role in prognosis of patient with diabetes and heart failure with reduced ejection fraction? My job is made easy by Alok Boss, background about the ARNI therapy, and as for the evidence and the data which are coming up from the time to time derived from the various studies, now it is a very important to treat heart failure in a proper manner, both for the endocrinologist, diabetologist, and even for the nephrologist people. So it is a very good integration between cardiodiabetes and renal treating physicians. Okay, so my job is to answer the question like NT-proBNP concentration. Is it possible to identify some of the patient of the heart failure with the use of NT-proBNP? Yes, it is, because the incidence is quite high, as Dr. Alok was already saying, that approximately 30 to 50% of the patient who are having diabetes, they tend to diagnose with the heart failure, and there is approximately 3.5 times increased risk of death and hospitalization because of heart failure with reduced ejection fraction, and there is increased all-cause mortality in heart failure with reduced ejection fraction, again approximately 3.5 times. So we all agree that heart failure is a common identity in type 2 diabetes patient. It is a neglected identity. It is underdiagnosed identity, and it is mainly responsible for cardiovascular mortality. So recognizing heart failure in the early part of the therapy is very, very important for all clinicians, not only cardiologists. It is also important for the endocrinologist, any physician, any metabolic physician who is treating all these sort of patient. And if you diagnose these patient in early part of therapy, believe me, it is going to pay to you, and you can certainly alter and save few life of the patient, and the quality of life is also altered because of the timely diagnosis of heart failure. So it is very, very important. So what about the anti-proBNP values? Does it holds a role in evaluation of overall status, thus facilitating the established and correct management in case of patient who is coming to the emergency department with the dyspnea, or this type of patient who is having increased breathlessness while doing exercise, or NIHA grade is decreasing. So in this subgroup of patient who was presenting as a worsening of a patient with the anti-proBNP measurement, even if you are not having facility of the echocardiography in the peripheral center. Nowadays, kits are available. So with the help of simple measure, you can diagnose heart failure. And not only this, you can use HSCRP and other inflammatory molecule to designate that this type of patient are having some inflammation going on, and you can decide on the therapy, newer therapy like a combination of ARNI or SGLT2 inhibitor in this subgroup of patient. So this is very, very important. So though anti-proBNP are not indicated to do in the follow-up to decide which type of therapy should be given, but it gives a prognostic importance in a patient. Suppose if you are treating a patient and anti-proBNP is rising more than 30%, that means your patient is deteriorating, and probably you are dealing a patient with a failing regime. Not only this, if the extent of anti-proBNP reduction is more, probably the outcome is going to be better. So sacubitril valsartan lowers anti-proBNP levels in a patient with diabetes, with heart failure, with reduced ejection fraction, and there is 25% reduction in anti-proBNP level with the sacubitril valsartan as compared to enalapril in patient with heart failure with reduced ejection fraction. Another question which Dr. Amit has given to me is, what is the impact of the sacubitril valsartan on the glycemic control and the use of insulin in patient with diabetes and heart failure with reduced ejection fraction? This is very, very important question. As we all know that insulin is one molecule which has got sodium retention capacity. So if you give insulin, the weight of the patient will go up, and by the virtue of the IGF-1 receptor action, it retains sodium. So a patient of heart failure, if you are giving huge amount of insulin, it is going to retain sodium, and ultimately it will cost in terms of worsening heart failure. So this is very important to reduce the dose of insulin if possible, if you are treating a patient of heart failure. So how you can do that? You can do that with the help of various insulin sensitizer agent. Of course, those agents should not be sodium retaining like pioglitazone. You should avoid that. But if you are using agent who are natriuretic like GLP-1 receptor agonist and SGLT2 inhibitor, those are the natriuretic agent. Certainly they can be used along with the insulin and they can be beneficial. But if you see the sacubitril valsartan also, this is also a molecule which has got natriuretic property and insulin sensitizing property by the virtue of increasing GLP-1 level. So this is very, very important cross link between the sacubitril valsartan and the insulin. So it indirectly increases the GLP-1 level, and hence it is a insulin sensitizer. So let's see what data says. This is all theory. So what data says, if you are using sacubitril valsartan, actually there is a significant amount of HbA1c reduction. And this HbA1c reduction is mainly because of the potentiation effect of GLP-1. So this is very, very important. And as Dr. Alok was pointing out, that these sacubitril, this is one molecule which has got many effects. this is one molecule which degrades the GLP-1. So this is a molecule which can increase the GLP-1 level apart from other pleiotropic effect of sacubitril/valsartan. So because of all this, there is a significant amount of HbA1c reduction if you are using this molecule as compared to AC inhibitor. Mind you, the AC inhibitors are also insulin sensitizer. So you are comparing an insulin sensitizer with an insulin sensitizer. Still, this molecule has got better effect and better HbA1c reduction. So, and nitrohc also. So this is very, very important. So effect of sacubitril/valsartan on insulin sensitivity, you can see there is a 29% reduction in new use of insulin once you are using the molecule along with the insulin. So my point is, if you are treating your patient of heart failure who is also a diabetic, if you add this molecule, because of mere improvement of the heart failure and because of the sacubitril/valsartan, the amount of insulin is going to reduce. And once the amount of insulin is going to reduce, the NHE receptor upgradation is less. So this is one receptor, this NH3, which is mainly responsible for the deleterious effect of cardiac remodeling. And because of this, less number of NHE receptor will be upregulated, so there will be better reverse cardiac remodeling, so hence beneficial effect. So this is a molecule which has got some action through NH3 one receptor also. So this is very important to initiate this kind of agent in Akshay, so that the oral anti hyperglycemic therapy can be minimized and dose of insulin can be reduced. So next question, I think this is the question for the Dr. Alok. Dr. Alok, please. Hello. Hello.
You stop sharing, then I will share.
Okay.
You stop sharing.
Okay. Give me some time. Yes. Go ahead.
So, is there any evidence with sacubitril/valsartan in Indian HFrEF patient? Paradigm HF Indian cohort, evidence of sacubitril/valsartan in patient with diabetes and HFrEF. As this trial was conducted even in Varanasi in Heritage Hospital, we were the co-PI, I was there. And 35% of the HFrEF patient in Indian Paradigm HF cohort were the diabetic patients. And approximately the 35% patients were sacubitril/valsartan and 38 were on enalapril. And by initiating the sacubitril/valsartan offers the similar protective effect to the Indian HFrEF patients. There was an 11% reduction in the risk of severe death and hospitalization in HFrEF patient on ARNI in comparison to enalapril in Indian HFrEF patients. And there was a 13% reduction in the risk of severe death in HFrEF patient with sacubitril/valsartan in compared to enalapril. Survival benefit. So 13% survival benefit. And by initiating sacubitril/valsartan to experience similar benefit in Indian HFrEF patient, there was a 22% reduction in risk of first heart failure hospitalization in Indian HFrEF patient with sacubitril/valsartan compared to enalapril. So there was a reduction in mortality. There was a reduction in combined endpoint of severe death and heart failure hospitalization. And there was a reduction in first heart failure hospitalization in Indian HFrEF patient with sacubitril/valsartan compared to the enalapril. And there was a 12% reduction in risk of all-cause mortality in HFrEF patient with sacubitril/valsartan compared to the enalapril in Indian patients. So treatment effect of sequential was certain between Indian and overall paradigm HF cohort. Treatment benefit for the mortality were similar between the Indian and paradigm HF cohort. So it was similar like to the overall paradigm HF population. So it is we can derive from it. The Indian population is behaving similarly to global population of paradigm HF as far as the beneficial effect of ERNI is concerned in heart failure population. So next question to the Asutosh. With SGLT2 inhibitor showing promises to the HFrEF patient, is there any evidence for the use of together in HFrEF patients? Over to Asutosh.
Yes, yes. Okay. So let me share the screen. So my slides are visible in full screen mode.
Yes.
Yes, sir.
So now coming to the one of very important question, is it possible to combine the SGLT2 inhibitor and ARNIC together? So as Dr. Alok was mentioning, if you ask this question 1 month back, it was relevant and somebody may debate over it. But now, since these things are becoming the part of guidelines, so it is now very clear that now we have a fourth pillar of management of the heart failure, and there is a space. So if you combine these agents like SGLT2 inhibitor and ARNI together, you are going to have additional benefit. So why I am saying this, let's explore this. The combination of the novel therapy versus the conventional therapy. The conventional therapy, I mean beta blocker, the AC inhibitor, and mineralocorticoid receptor agonist. If you compare this conventional therapy with the novel new combination therapy like ARNI, mineralocorticoid receptor agonist, and SGLT2 inhibitor, these are superior and beyond controversy. This combination is doing better than the AC inhibitor, beta blocker, and mineralocorticoid receptor combination. And the reason, one of the reason is the SGLT2 inhibitors are the agents which are now very important agent who are reducing the interstitial edema. So this is very important. This point was earlier not addressed by the other molecules. So the tolvaptan, the SGLT2 inhibitor, they are the agents which are also acting on the interstitial part, and there is a concept that now new concept is coming up, and there are new targets are there. So because of the complementary action, if you combine these three molecules, certainly you are going to get a better evidence as far as the theory goes like. So there is a concept of tissue congestion and there is a concept of vascular congestion. So if you want to deal with the tissue congestion, probably SGLT2 inhibitors are the one which can make an edge over that. But if you see the ARNI and mineralocorticoid receptor agonist and other agents, they are very good in treating the vascular congestion. So because of these probable explanation and the action on the pulmonary system and the action on heart failure with preserved ejection fraction and the older woman, probably the combination of all these three agents are doing much better as compared to the other agents. So this is the theory. And what about the evidence? You can see here the combination of the ARNI and SGLT2 inhibitor shows better clinical outcome as compared to conventional therapy in case of heart failure with reduced ejection fraction. You can see it is better, superior in terms of cardiovascular death, hospitalization for heart failure, cardiovascular death, and all-cause mortality. So all the points it is scoring better, and as compared to the conventional therapy, these comprehensive combination therapies doing better, and that's why they are now a part of the guideline. And not only this, if the combination of the ARNI and SGLT2 inhibitor shows better event-free survival for the heart failure with reduced ejection fraction as compared to the conventional therapy. So beyond doubt, it is clear that if you are combining SGLT2 inhibitor with ARNI with mineralocorticoid receptor agonist, probably you are going to get better survival better overall result as compared to conventional therapy, be it in a young patient, be it in an older patient. In all subgroup of patient, actually the survival is increased. So yes, we can combine ARNI with SGLT2 inhibitor, and if you are combining these two agents, you will get a very good result. So over to Dr. Alok.
Stop sharing.
Okay. Yes.
So the question is, does the use of sacubitril valsartan improves the quality of life in patients with diabetes and HFrEF? I think there is a study which has shown sacubitril valsartan provides a 17% improvement in quality of life probability within 8 months compared with the enalapril as per the analysis of Paradigm HF based on the Kinesis CT cardiomyopathy questionnaire, and age difference between the treatment group in KCCQ score. If you are treating the patients with the sacubitril valsartan compared with the enalapril, there is an improvement in quality of life approximately 9 years. Your patient will feel 9 years younger to in comparison to the enalapril. To summarize, the patient with diabetes and heart failure are likely to have an increased risk of mortality. Sacubitril valsartan reduces the risk of mortality and improves quality of life with diabetes and HFrEF. So, patients with diabetes and HFrEF are at increased risk of mortality over a period of time. Sacubitril valsartan is now recommended as the first-line therapy for all HFrEF patients. There is no need to wait, like a Paradigm HF is the trial where stabilized patients were taken, but the publication of Pioneer study, transition study, and Prove HF study, now the approach is direct ARNI approach. If patient can afford, then start with the ARNI rather than ACE inhibitor. And sacubitril valsartan reduces the risk of CV death and all-cause mortality and improves quality of life in patients with diabetes and HFrEF. Time is essential in a heart failure patient, so is initiating evidence-based treatment in HFrEF patient to improve the survival is important. So, as Dr. Ashutosh have explained, there is an analysis by McMurray et al. If you are initiating with the conventional therapies, a ACE inhibitor, beta blocker, followed by MRA, instead of these three pillars, if you are giving beta blocker, ARNI, MRA, and SGLT2 inhibitor, these 4 drugs you are combining, then you are adding 6 to 8 years of life to your heart failure patients. And most effective drug, in fact, most effective therapeutic modality in heart failure is beta blocker, followed by ARNI, then followed by ICD, CRT, and MRA. And now SGLT2 inhibitor is a new addition, and with the SGLT2 inhibitor, Emperor reduced, Emperor preserved is showing the promising data. So I think ARNI and SGLT2 inhibitor, these 2 class of drug will really change the landscape. Or one important paper came in ESC yesterday. Now the dapagliflozin have been shown to reduce the risk of sudden death, reducing the risk of ventricular arrhythmia as well. Earlier, we are ACE inhibitors and ARB don't reduce the sudden cardiac death. It is beta blocker reduces the sudden cardiac death, and it is the ARNI which reduces the sudden cardiac death. It is MRA which also reduces the sudden cardiac death. Now, SGLT2 inhibitor is also reducing the sudden cardiac death. I think with these 4 class of drug, we are now reducing the pump failure death as well as sudden death. So, because sudden death is also one very important factor, and it is boon for our Indian patients, because most of our patients, because of the price of implantable cardiac defibrillator, which is very high in the tune of 3 lakhs to 4 lakhs, and every 5 years you have to replace the battery, again 3 to 4 lakhs. So most of our patients need not to be not able to afford the ICD therapy. So with addition of ARNI and SGLT2 inhibitor over and above beta blocker and MRA, will really changing the landscape in the management of heart failure. So thank you all. Over to the Amit Srivastava.
Thank you, our speakers. I would like to have opinion of our expert panelists, Dr. Vineet Agrawal and Dr. Suyash Tripathi. Okay, so I have some more questions here in the viewers link. We have almost more than 150 viewers on my viewers link. So the first question to both of you are, what is your experience? What is the background when you start? Which is the first drug which you start in heart failure?
You know, in the management of heart failure, our first priority, it depends upon the clinical presentation. If patient is in gross failure, then we start with the diuretics, first decongest the patient, and to add with the beta blocker and ARNI. And my approach is to start with the low dose of both drugs, because it has been seen with ACE inhibitor and beta blocker, rather than getting the highest dose of one drug, then adding another drug. It is better to combine low doses of the two different class of drug. So I combine with the small doses of ARNI with the small doses of beta blocker, and most of the time MRA is in combination with the diuretic I start with, and gradually your up titration should be depending upon the clinical presentation of the patient, blood pressure of the patient. That is very important. And once you are up titrating ARNI, then you should always try to reduce the dose of diuretic. Otherwise, chances of hypotension will be high. So, because ARNI itself, by potentiating the action of BNP by neprilysin inhibition, have the diuretic action. So, whenever you try to increase the dose of ARNI, try to reduce the dose of diuretic.
So, what is the timing to introduce SGLT2 inhibitor? Yes, Dr. Ashutosh.
Yes. In my opinion, what I see in my clinical practice, most of the time we see a patient who are relatively less sick, but still what we follow that if my patient of heart failure is who is having blood pressure less than 90 or a patient who are having hypotension, then probably you are not able to start all these agents. And if the ECG is having QRS complex widened, so in those subgroup of patient, again, after excluding those subgroup of patient, again, as Dr. Alok has rightly pointed out, if the patient is having vast congestion, then diuretics are the therapy, and the combination of the drugs or drugs in lower doses and then gradually up titrating is a very important aspect. So most of our patients are also diabetic, so we want to use SGLT2 inhibitor in those subgroup of patient as a preferred oral anti-diabetic agent if blood pressure allows. So at the time of discharge or at the time of latter part of the hospital stay in worsening heart failure also and the chronic stable heart failure patient also, we used to add the SGLT2 inhibitor after ARNI and beta blocker.
Now,
Dr. Ashok, yes, Dr. Alok, one more thing is there. Actually, the problem which I am facing regarding this question, what I am facing right now is those patients, I am very comfortable in using ARNI in heart failure patients in all spectrum of heart failure, ADHF or chronic heart failure, everything. But what I have seen recently, that when I'm adding SGLT2 inhibitors to this combination, ARNI combination, then I'm facing problems. So what is your take over it?
Actually, now, if you see the McMurray approach we have, which he have explained, now loop diuretics, all of you know, what loop diuretic does. Loop diuretics produces a state of volume contraction by which it activates the RAS activation. Advantage of SGLT2 inhibitor, what he had advised, rather than using a loop diuretic, use SGLT2 inhibitor as a diuretic. Because SGLT2 inhibitor have a diuretic action where there is a diuretic action, but secondary RAS activation is not there. It is also one of the potential mechanism of action have been of the benefit of SGLT2 inhibitor in heart failure, because all landmark trial, if you see Emperor outcome and DAPA, before this heart failure trial, even original diabetes trial, there was a reduction in heart failure hospitalization, which even in the normal population, normal diabetic population was there. So if you are adding SGLT2 inhibitor, then probably you need, if your patient is clinically decongested, then probably stop your loop diuretics. I have also find out if you are adding SGLT2 inhibitor, then you will have hypotension and lot of weak patient will complain of lot of weakness. So now what I have adopted, stop loop diuretics. And when you are adding
Definitely.
SGLT2 inhibitor,
Loop diuretics will cause neurohormonal reflex activation and it will have deteriorating effect.
so yes, add SGLT2 inhibitor, stop torsemide, keep MRA with you, and otherwise hypotension will, a lot patient is complaining of weakness. I have also encountered this.
Yes.
Because once you are adding SGLT2 inhibitors, then I think you will get the diuretic effect.
Another important point, since we are using SGLT2 inhibitor for longer period of time, as in a diabetic patient, start SGLT2 inhibitor also in low dose. There is no need to start in a full dose also. So if you are using correctly choosing your patient and you are using right dose and you are in no hurry actually titrating the dose slowly, then probably your patient will tolerate the things.
I think McMurray have clearly explained to start with the SGLT2 inhibitor and beta blocker as a first line. And after 1 week, call the patient and add ARNI and afterward MRA. What is the fundamental of that? What he suggested, you will get the diuretic effect from the SGLT2 inhibitor, and beta blocker is the most effective drug in reducing the mortality, what he suggested. And after 1 week, see the response, then add ARNI, and after that MRA. Within 4 weeks, you should have all 4 drugs to your patients. That have been suggested. So now I think with time we will learn to treat congestion in heart failure without loop diuretics with SGLT2 inhibitor. I think that we have to learn over the period.
Very important point. I just want to emphasize. I was going through one of the review article of Nature Cardiology, which has given a concept of tissue congestion versus vascular congestion.
Yeah.
The tissue congestion, those subgroup of patients, you must also be finding some of the patient of COPD or some of the patient of the heart failure who are having predominantly tissue congestion. So you have to recognize those subgroup of patients who are having predominantly tissue congestion. So how to recognize the patient who are having predominantly tissue congestion? So if you do CA125 or other biomarkers, there are some other biomarkers. So if you are dealing with a patient in spite of having all 4 agents, and if you are having predominant tissue congestion, like your CA125 levels are high, person is having pedal edema also, the pro-BNP levels are settled, CA125 levels are high. In those subgroup of patients, you can increase the dose of SGLT2 inhibitor so that tissue congestion can be taken care of. So this is another new concept which is coming up, and this is another exciting area where tissue congestion can also be an important target, and there can be another agent which will further improve the outcome in case of heart failure. Whether ARNI is affecting the tissue congestion or not, this is another area of research. The talvaptan is one drug which is also affecting the tissue congestion. So there are a lot more things going in and there is new hormonal theory which are coming. So only time will tell that there are other established that may come into the picture with a new target.
Hello. Yes, since we are running short of time, I'd like to ask one last question to Dr. Ashutosh from our viewers link. So what is the role of albumin in heart failure? This has recently been asked in many meetings. What is the role of albumin if the albumin levels are low, and how we should go with it?
So actually, we all know that once the albumin is low, there is increased plasma volume, and this is going to increase the actually intravascular volume, and this may be one of the decremental factor. Another important point which everybody should know, that low albumin is a prognostic marker in case of heart failure, because a cardiac cachexia or other inflammatory thing is there. So if your patient is having low albumin in case of heart failure, probably that subgroup of patient is having bad prognosis. So merely treating the albumin is not going to solve the problem. Yes, if you are very sure that your patient is euvolumic and you are sure that you are not going to increase the intravascular volume, probably in subgroup of patient you can give albumin. Otherwise, there is no clear-cut role as for the guideline which says that albumin should be given. Dr. Alok, please, would you like to help me in this regard?
No, I think as you rightly pointed out, albumin tend to reduce in any chronic disease. Yes. So in chronic heart failure, you will have the reduced albumin. So I think treating the heart failure to its full extent with all guideline directed medical therapy should be our aim. We should not infuse albumin in heart failure because it will further precipitate the heart failure. So here condition is different from the chronic liver disease. This CHF, as all of you know, reduced albumin is a marker of chronic disease because of any reason.
Thank you, Dr. Alok and Dr. Ashutosh. Thank you, very informative session, and it has cleared many of my doubts. So we'd like to proceed, since we are running out of time, we'd like to proceed to our next session. The moderator of our session is Dr. Ajay Kumar Belia. He is senior consultant cardiologist at Metro Hospital Faridabad. He has more than 18 years plus experience in the field of cardiology, having done more than 10,000 procedures, including intra-aortic balloon pump, temporary pacemakers. He have been doing and assisted coronary angiographies through femoral or brachial or radial route. He has done angioplasties, coronary, renal, carotid, and peripheral angioplasties. He has done balloon valvuloplasties, permanent pacemaker implantations, expert in putting invasive lines and routinely doing it, including femoral, subclavian, radial, jugular lines. He is expert in invasive and non-invasive ventilatory procedures, managing all kind of cardiac emergencies, including the myocardial infarction, cardiorespiratory arrest, cerebrovascular accidents, and non-cardiac problems like diabetic crisis, hypertensive emergencies, etc. He has extensive experience of working in cardiac intensive care unit, 7 peer-reviewed publications in index journals. He is member of API, IDF, CSI, India, ACC, ESC, and RSSDI. In this session, Dr. Mohit Saxena will be chairing this session. Dr. Mohit Saxena is alumni of prestigious SMS College, Jaipur. He has 14 years research experience in the field of cardiac and vascular surgeries. Dr. Saxena worked as assistant consultant in Fortis Escort, Jaipur. He was assistant professor at Bhopal Memorial Hospital, MP. He was associate consultant cardiac surgeon at Baroda Heart Institute, Baroda. Currently working as consultant cardiac and vascular surgeon at Shubham Super Specialty Hospital, Varanasi. His field of interest is off-pump CABGs, total arterial revascularization, mitral valve repair, minimally invasive cardiac surgeries, PTA closures, etc. He has 13 peer-reviewed journals and 2 chapters in books, and principal investigator of various multi-centric clinical trials. So our next topic is on glycemic variability, and we'll be primarily focusing on vildagliptin. And our speaker is Dr. Saqib Ahmed Khan. He is consultant endocrinologist, Chandan Hospital, Lucknow. and he has done his MBBS from BRD Medical College, Gorakhpur, MD Internal Medicine from GSVN Kanpur, DM Endocrinology from LLRM Hospital Meerut. He is MRCP SCE UK Diabetes and Endocrinology in June 2019. He has participated and trained Endocrine Fellow Series Type 1 Diabetes Care and Management from Chicago, USA. He has participated in many national and international conferences, many publications to his credit, which are published in Journal of National and International Repute. He is currently working as a consultant endocrinologist in Chandan Hospital, Lucknow. So over to Dr. Saqib Ahmed. Will you be sharing your screen, Dr. Shakib?
Yes, yes,
Okay,
yes.
so on to you, Dr. Shah.
Thank you, thank you. So thanks for the nice words. So probably my slides are visible to all of you. Good evening, everyone, and thanks for this wonderful opportunity. So today I'll be discussing this glycemic variability. So we have started testing our diabetes with urine glucose levels. It was an ancillary and an ancient kind of testing. Even from the ancient time, we have utilized this, that aunts were attracted to urines of some diabetic people. Then came the concept of blood glucose fasting and PP, and we have standardized that at those investigations. Then came the concept of further refinement of glycemic variability in the form of HbA1c and some other assays, from in which HbA1c was standardized, which used to give us the value of median blood glucose level of last 2 to 3 months. But now with the further advancement in the form of CGM, that is continuous glucose monitoring, now we have some other variables which can tell us about interday as well as intraday variability, which themselves are having a say in CV mortality and other risk factors. So we'll be discussing in the form of introduction of this glycemic variability, important metrics for assessment of glycemic variability, effects of glycemic variability on adverse clinical outcomes, clinical implications of glycemic variability in type 2 diabetes, effects of anti-diabetes drugs on glycemic variability in patients with type 2 diabetes, the before inhibitor about them, and then we will conclude. So as I've said, that urinary glucose estimation was not enough. Then came the further refinement for fasting PP, HbA1c, and now HbA1c was not enough for those people who are having more fluctuations, like up 2% when we are comparing them with same kind of HbA1c, like HbA1c of 7. It means that they are having a median blood glucose level of 154 for last 2 to 3 months. But some of them might be having more crests and troughs, more ups and downs, as compared to those who are having lesser variation, like just variation from 144 to 164, while some will be having a lot of variation as compared to this. So this has forced us to search for other glycemic variables. So HbA1c doesn't take into account fluctuations in blood glucose level in those 3 months, and what fluctuation causes to our metabolic health. So these fluctuations are never welcome in metabolic health. Any smoother profile is always welcome. These yo-yo phenomena or this crest and trough in terms of glycemic control or blood pressure control or lipid control are always having an extra hazard. So it leads to increased risk of hypoglycemia, particularly at target HbA1c levels or lower, and more glycemic excursions into the hyperglycemic range, particularly at higher HbA1c level. So, and they ultimately result in increased risk of micro and macrovascular complications, which the recent data is showing, and there is an impact on psychological well-being and quality of life. We know that People will feel like eating when they will be having hypoglycemia. People will not be feeling well when they will be having those variation in the form of dips of blood glucose level. So the concept of glycemic variability has recently emerged as another measure of glycemic control, which might constitute an additive to HbA1c to discern diabetic complication. And we know that the purpose of treatment of diabetes per se is prevention of complications. So this tool might help us better. So this glycemic variability is an important metric to consider when assessing glycemic control in clinical practice, and it is defined by the measurement of fluctuations of glucose or other related parameters of glucose homeostasis over a given interval of time. There are two types of glycemic variability according to the length of time interval where we are subjecting to test a patient. There is short-term glycemic variability, glycemic fluctuations within day or between days, and long-term glycemic variability like glycemic fluctuations over months to years, which can be known by HbA1c. Increasing evidence supports the role in development of diabetic complication. Like advanced study has shown us that glycemic variability was significantly associated with both macro and microvascular events, and it was significant. Devote has also told us that day-to-day fasting glycemic variability was significantly associated with severe hypoglycemia and all-cause mortality with an extra risk of 58% and an hazard risk of 4.11 respectively in them. Devote trial has also established that visit-to-visit variability in fasting blood glucose increases the risk of all-cause mortality and cardiovascular events. And Empiric has also shown that increase in glycemic variability correlated with an increased risk of subsequent cardiovascular death and cardiovascular death or hospitalization due to heart failure. In type 2 diabetes, long-term glycemic variability is correlated with an increased risk of both microvascular as well as macrovascular complication. So what are the important indices or metrics for assessment of glycemic variability? There are a lot. While some of them might be very important in an interpretation of a CGM data, like the above range values, below range values, and some other more subtle kind of thing like standard deviation, which says variation around the mean blood glucose, coefficient of variation, that is magnitude of variability relative to mean blood glucose, MAGE or mean difference from peak to nadir, that with the same HbA1c, a patient might be having as high as 210 and as low as 65, and the second person might be having just a variability from 160 to 120, which is more welcome. The difference between a current blood glucose reading and a reading taken hours earlier is defined by continuous overlapping net glycemic action or CONGA, and MAG or mean absolute glucose, which says the absolute differences between sequential readings. Mean of daily differences, the average glucose profile, and low blood glucose index or high blood glucose index, ADRR, which says about average daily rise range, and TIR, that is time in range, which is very important, and it is even becoming more and more standardized with the more hard data we are having, that it is a very important factor, and it is a very helpful tool. We should be having different kind of target time in range in different kind of people across the different spectrum of condition. So effects of glycemic variability on adverse clinical outcome. Why is it important? So glycemic variability, especially in the hyperglycemic range, is associated with adverse event because it leads to more and more generation of oxidative damage and mitochondrial damage, which is associated with the long-term complication. So, and not only this, it is also associated with an increased risk of this increased glycemic variability is associated with more risk of hypoglycemia, more microvascular complication, and more cardiovascular complication. And even it has been seen that cognitional disorder is also more important in those who are having more variability in terms of high GV. So it's an independent predictor of hypoglycemia when you have two sets of glycemic variability. One person is having the glycemic this self-monitoring of blood glucose standard deviation of less than 4.6. He is having lesser number of hypoglycemia episode, while those who are having more standard deviation, that is they are having a more variation across the mean range, they will be having greater chances of hypoglycemia. So higher glycemic variability doubles the occurrence of hypoglycemic events. So when we talk about relation between glycemic variability and microvascular complication, the pathogenic link between glycemic variability and microvascular complication is the generation of leukotoxicity and oxidative stress, which leads to epigenetic changes and ultimately endothelial dysfunction and development of microvascular complication when it continues for a long duration of time. Along with this, hypoglycemia and hyperglycemic spike further lead more and more oxidative stress, and when this continues for long term, it leads to more and it is also associated with lipotoxicity, which further contributes in more and more oxidative damage. So this glucolipotoxicity as well as fluctuation, they lead to oxidative stress and more damages, which are even permanent in that progeny because of epigenetic changes occurring due to these harmful effects. So glycemic variability and cardiovascular health, when we talk about this, there are changes in systolic blood pressure and diastolic blood pressure, increased coefficient of variation of fasting plasma glucose, and that results in increase in mortality. It results in more and more atherosclerosis, arterial stiffness, and carotid intima medial thickness, which is a marker of atherosclerotic burden, is also increased with more glycemic variability. This Verona diabetes study has shown in this Kaplan-Meier estimate that the survival probability decreases when we have the adverse coefficient of variation. When the coefficient of variation increases, that is glycemic variability increases, the survival chances increases with the passage of age. So a patient who is having more stable blood glucose profile will have more chances of survival with the passage of time, and it is shown by this Verona diabetes study. So what is the clinical implication of glycemic variability in diabetes? So it is the manner of blood glucose lowering which may be as important as the degree of glucose lowering. As I've said, that it is very important to avoid those yo-yo phenomena or deep fluctuations in metabolic parameters. So we should consider therapy recommendations to achieve these changes slowly and steadily, and ultimately into the target range, and their impact on day-to-day glucose variation should be thought of before initiation in any particular patient. Importance of reducing glycemic variability is most relevant in type 2 diabetic patient undergoing more aggressive glucose lowering. These individuals are at an increased risk of severe hypoglycemic episode, and which is a major determinant of cardiovascular disease events. So we should be even more cautious in those patients, and we should safely lower the hyperglycemia with avoidance of marked glucose fluctuation as well as episodes of hypoglycemia, because it may be a deterrent of having a euglycemia in any patient, because once a patient will be having hypoglycemia, he might be very skeptical because it is a near-death experience for any person. The effects of anti-diabetes drugs on glycemic variability. When we talk about this, acarbose leads to decrease in intraday glycemic variability, and it has been proven in this 1 week double-blind randomized control trial as compared to placebo. Especially postprandial variability with acarbose versus placebo was established. When we talk about DPP-4 inhibitor, which are associated with glucose dependent insulinotropic agent, and so they are expected to cause this benefit, and they leads to when we talk about sexagliptin, they leads to similar glycemic variability reduction in both sexagliptin and acarbose. And we talk about sitagliptin, and when we compare them with glimepiride, there is a significant mean amplitude of glycemic excursion, but it was not found with glimepiride. So there was a benefit in glycemic variability with sitagliptin as compared to glimepiride. And when we compare vildagliptin against pioglitazone, the glycemic variability reduction seen only with vildagliptin. So DPP-4 inhibitors are at par with acarbose and are better as compared to sulfonylurea or pioglitazone in these small trials. When we talk about GLP-1 receptor agonists and we compare them with just insulin titration alone, the addition of liraglutide to insulin therapy has shown significant reduction in glycemic variability. And when we talk about SGLT inhibitor like dapagliflozin and we compare them with sexagliptin, there was no significant differences in glycemic variability between DEPA and sexagliptin in pre-Ramadan and during Ramadan. So even when the risk of different complication is there with fasting, like with dapagliflozin, still it was offering the lesser glycemic variability and it was comparable to DPP-4 inhibitor, that is sexagliptin. So DPP-4 inhibitor is an effective therapy for reducing glycemic variability in type 2 diabetic patients. And when we talk about the role of DPP-4 inhibitor, so it enhances GLP-1 preservation and expansion of beta cell mass through inhibition of apoptotic pathways. And we know that because of this physiological mechanism, they are independent of duration of disease. So this incretin axis, this overactivity, which we have seen that is even more important in us in Asian population as compared to Western counterpart. It will be yielding its glycemic anti-hyperglycemic efficacy even with those patients who are having an endogenous insulin deficiency. So it is independent of duration of diabetes. And since glycemic variability is highly correlated with pancreatic beta cell dysfunction, even in patients whose type 2 diabetes is well controlled, DPP-4 inhibitors are considered as an effective therapy for reducing glycemic variability. So this forest graph is showing clearly that a lot of studies has shown that when you compare DPP-4 inhibitors versus other oral anti-hyperglycemic drugs, a lot of the studies has shown that they are better in terms of glycemic variability. They have reduced mean amplitude of glycemic excursion significantly in some studies, while in some of them they were numerically better but not significantly better. But most of them, when you compare them and combine them, they show a better glycemic variability as compared to other oral anti-hyperglycemic drugs. So what is the role of vildagliptin in reducing glycemic variability? Vildagliptin has shown improvement in all indices of glycemic variability, which is significant whether you talk about standard deviation, interquartile range, Conga, J index, or on mean amplitude of glycemic excursion. They all are significantly better as compared to placebo, and all of them are significant. So this lower glycemic variability with vildagliptin was evident even as compared to sitagliptin in this graph and in this study, where the mean amplitude of glycemic excursion response was compared, and it was significant, and it was having almost 4 times lesser glycemic variability as compared to sitagliptin in this study. So it was a good greater reduction in MAGE with vildagliptin compared to sitagliptin, and lower glycemic variability with vildagliptin compared to sitagliptin. When we talk about vildagliptin and its impact on blood glucose and mean amplitude of glycemic excursion, when we compare vildagliptin and sitagliptin, this J Victoria study has shown that it was associated with lesser number or numerical value of 24-hour blood glucose level with vildagliptin as compared to sitagliptin, and also the mean amplitude of glycemic excursion was also less, and it was significant. So vildagliptin has shown a significant reduction of mean amplitude of glycemic excursion, while the blood glucose level after supper was significantly lower as compared to sitagliptin. Just to conclude my talk, glycemic variability should be an important metric to consider when assessing glycemic control in clinical practice, especially with the modern era where CGM and those devices are available to assist us. They will minimize glycemic variability, and it is associated with this minimization of glycemic variability is associated with lower risk of long-term micro and macroscopic complication, improvement in quality of life, and more treatment satisfaction and more adherence in chronic disease like diabetes. And improved treatment adherence results in a lot of good things, whether you talk about the patient satisfaction as well as the long-term outcome of the population you are treating. So with this, I would just end my talk and would ask for any question if you have.
Thank you, Dr. Saqib, for the wonderful presentation. Am I audible, Dr. Saqib?
Yes, yes, yes.
Yeah, Dr. Saqib, this is Dr. Mohit. So there are two questions from the audience side in the chat box. The first and the basic question is, how do we measure the glycemic variability?
So as I've said that when you talk about the practical consideration, this time above range and time below range and time in range is the criteria which is there.
CGM.
And when you get the data after this CGM is available in two forms. One is for retrospective evaluation, where after application for 24 to 72 hours or for 7 days, you analyze the data retrospectively, or more advanced real-time CGM data, where you can connect with Bluetooth device and you can see. So it gives you trend where every 5 minutes you will be having a blood glucose level, and that will give you trend. So you can see that time above range, how much time you have spent on time above range, which is divided in two range, that is level 1 and level 2, that is 180 to 250 and above 250, and time in range is further divided into 70 to 55 and less than 755. While for the research purposes, a lot of further indices have been chosen, a lot of metrics have been chosen, which I have discussed, like mean amplitude of glycemic excursion, how much from the standard deviation a patient's data is moving, how much interday variation is there, so interquartile variation and those things. But they are for research purposes, that how two different classes of drug are behaving, how we can further improve. So these are the thing for research purposes, and for the practical purposes we can use time in range, time above range, and then time below range, which is very helpful, especially in those where you are missing that. And it is actually a therapeutic thing where you can do it, and you can tailor the therapy of a particular patient, that where he is at fault. Like if the patient is having peaks at 4 or 5 p.m. and the patient is taking a snack which is not healthy, and the patient is not walking, then you can ask them some leading question about that timing, and you can correct it. You can change the medication accordingly. Like if the patient is not aware of hypoglycemic episode, the patient is having autonomic neuropathy, patient is having hypoglycemic unawareness, and the patient is going into hypoglycemia in the night time, you can know that at which time the patient is faltering, and you can correct. Like if the patient is having extra dosage in the night time, you can decrease the dosage. If the patient's requirement is not being met, the patient is having late night hyperglycemia, then you can accordingly increase the dosage of long acting insulin. So it is very important and very useful in choosing the therapy also.
Thank you, Dr. Saqib, for your presentation and time. We move ahead for the next presentation. The next presentation is by very eminent speaker, Dr. Madhukar Rai, and he will be speaking on hypoglycemia, the endocrinologist perspective.
Let me take the privilege of introducing Dr. Madhukar Rai. His name needs no introduction as such. Dr. Madhukar Rai has done his MBBS and MD and DM in endocrinology, and presently he is a professor of medicine and ex-HOD in the Department of Medicine, BHU, Varanasi. Dr. Rai is a respected teacher as well as a research guide mentor for a number of postgraduate and doctoral students. Dr. Rai was instrumental in developing a state-of-the-art infectious disease research laboratory in the Department of Medicine at IMS BHU. He is a principal investigator in clinical and lab studies of leishmaniasis and on many other trials and research projects funded by esteemed organizations such as the National Institute of Health USA, National Institute of Allergy and Infectious Disease USA, the Infectious Disease Research Institute USA, and the Bill and Melinda Gates Foundation USA, and so on. Dr. Rai has published over 50 research papers in national and international journals and contributed chapters on textbooks. He is a co-editor of a book on pediatric endocrinology and paper cited in one of the most widely read textbooks of medicine, the Harrison Principle of Internal Medicine, in the 16th edition. Dr. Rai has been on the organizing committee of several medical conferences and is on the governing body of organizations such as Association of Physicians of India and Endocrine Society of India. He is invited faculty in various national and international conferences and delivered many lectures across the country and overseas. So, welcome, Dr. Rai, and it is over to you. Over to you, Dr. Rai.
Yeah, thank you, Chairperson, for that excellent introduction. And I'm probably the last speaker, isn't it?
Yes, sir. Yes, sir.
And how much time do I have?
Sir, we have around 20 minutes.
Okay, I'll try to be in time.
Yes, sir. Thank you.
Share. Can I start sharing my slides?
Sure, sir. Please go ahead, sir.
Last वाला session में pre-total लोग रखना चाहिए. Okay. So am I audible?
Yes, sir. You are audible, sir. Please go ahead, sir.
Okay.
And your slides are also visible.
Okay. So this last presentation is on a very, very important topic, and hypoglycemia. And you must have, over last 20-25 years, we have seen a very different facet in the development of diabetes. One is on the management, another is on the monitoring. The monitoring part, you must have heard from the previous speaker, that we have moved on from cell blood glucose monitoring and glycosylated hemoglobin to glycemic variability, to time in range, to time above range, and to time below range. And why have we gone into all these things? Only because we have got better and better tools to monitor and better tools to achieve these objectives. Because before that, when we were students or when we were treating diabetes, the only concern was to prevent glycemic related symptoms. Subsequently, we started controlling the blood sugar with the aim of preventing the microvascular complications. And unfortunately, studies after studies, they show that controlling blood sugar does not lead to benefit on the macrovascular events unless we have got a multifactorial approach for the management of diabetes. Now, once we started achieving tighter blood sugar control, it always came with a side effect, an iatrogenic effect, I would call it as, and that was hypoglycemia. And sometimes this hypoglycemia could be very, very detrimental. So at one end, we are trying to achieve a very good control, as near as normal, in order to prevent complications of diabetes. But we have got the drugs which are causing control of blood sugar, they are also causing hypoglycemia. And this hypoglycemia in acute setting could be fatal. And in chronic setting, there are results to suggest that it may lead to detrimental effect on the cardiovascular or the macrovascular and microvascular outcomes.
Excuse me, sir. Sorry to interrupt you. Your slides are not moving ahead, sir.
They are not moving, they are just static.
Yes, sir.
I will be moving it.
Yes, sir. Yeah, okay, sir.
So, with
Please.
this brief introduction, what I would say is between the tight blood sugar control, the evolving strategy of management, what we find the Achilles heel of any diabetes management program is hypoglycemia. And hypoglycemia in acute setting could be fatal, and chronic setting, it could be detrimental to the cardiovascular health, which we are trying to do by achieving a better blood sugar control. So we will be covering this aspect of hypoglycemia on the what is the prevalence of hypoglycemia, what are the major concerns with use of oral anti-diabetic drugs, and how can you identify hypoglycemia? If there is hypoglycemia, what are the complications? How does hypoglycemia affect the physiology, pathology, and of course, the patient becomes fearful when it encounters hypoglycemia and there is problem of adherence to medication. If the patient develops hypoglycemia, how are you going to manage it? Now, do we have drugs which can control blood sugar without causing hypoglycemia? And what are the guidelines recommendation? And then finally, we'll be having a concluding slide. Now, in Indian setting, if you look at the hospital-based patients where intensive blood glucose monitoring is done and patient blood sugar level is around 180, what you find is 96% of the patients were associated with more than one or other symptoms of hypoglycemia. This is a very, very high figure. Quarter of them report to have severe hypoglycemia. And what do you mean by severe hypoglycemia? It is a life-threatening hypoglycemia which needs assistance in controlling hypoglycemia. Patient is to be given IV fluids or IV glucose and other things. Now, in a cross-sectional study on a chronic care from South India, the study showed that the cumulative incidence of institutional hypoglycemia was 12.36%. This is one institution. And out of which, so out of this 12.36%, 26% were asymptomatic. It means a lot of hypoglycemia, they go unrecognized and they can do some harm. So definitely hypoglycemia when you're trying is an important risk factors and iatrogenic thing which can cause serious complications. Now, if you are practicing diabetes, you should know that hypoglycemia with oral anti-diabetic drugs or anti-diabetic drugs per se occurs only in two situations. So that's one is when you're using sulfonylureas, they cause tonic release of insulin and consequently they will cause hypoglycemia. Another drug which has got high propensity of causing hypoglycemia is insulin. Meticlinides are short-acting insulin secretagogues. The chances of getting hypoglycemia is very less. That too in patients with renal insufficiency. So, if your diabetic treatment regimen is containing sulfonylurea or insulin, you should always be very, very cautious in seeing that whether this patient is likely to develop hypoglycemia. Now, what are the symptoms of hypoglycemia? Essentially, the symptoms of hypoglycemia are quite variable and it could be at times very protein. But if you can divide it into two parts, one is autonomic activation. Whenever there is a hypoglycemia, the body tries to overcome this hypoglycemia by causing increase in the sympathoadrenal stimulation immediately, which leads to a lot of sympathetic activity. And subsequently, when the brain doesn't receive glucose as a fuel, you start getting neuroglycopenic symptoms. So what will happen if you've got excessive sympathetic activity? You will have excessive sweating, you got a feeling of hunger, you start shaking. So a patient of diabetes should be taught about these symptoms, that if you start sweating without rhyme and reason, you start getting hungry, you start shaking, you have got a strange feeling of restlessness, then you should start suspecting hypoglycemia. Now, if you allow it to progress, what will happen? The neuroglycopenic symptoms will supervene, and then you become dizzy, you have blackouts, you can be extremely fatigued, you will faint, or there could be mental confusion, and consequently you will land up in coma. And if not treated, it can cause a vegetative state of permanent brain damage, hypoglycemic brain damage. So this is the situation in acute glycemic episodes. Another problem is patient can develop nocturnal hypoglycemia. Now this largely goes unrecognized and it can do damage. And sometimes if the patient is not aroused, the patient can land up in coma. And how do you recognize that these patients are going into nocturnal hypoglycemia is if the patient gets a drenching sweat at night, he's got hunger or he gets nightmares at night. And when he gets up in the morning, he's got headache and he has got, he's not very feeling well. Then you should start suspecting that probably the patient could have hypoglycemia. Classically, when we teach what is hypoglycemia, we talk of Whipple-Strad. And what does it mean? That there are the symptoms which you have mentioned: excessive thirst, tremulousness, perspiration, drowsiness, and gradually landing into coma. These are the symptoms of hypoglycemia. And if they are occurring in a situation where the blood glucose is low, and then when you give infusion of glucose, these symptoms revert very rapidly. This is called as the Whipple-Strads. The Whipple-Strad is a typically proof of principle whether the patient is getting hypoglycemia. But sometimes you can get asymptomatic hypoglycemia. Hypoglycemia, patient is unaware unless the hypoglycemia becomes very, very severe, especially in nocturnal situations. So these are the symptoms of nocturnal hypoglycemia. Now, how could hypoglycemia complicate your problems? In short term, if there are acute symptoms, whether they are autonomic or what we call it as a sympathoadrenal, there's a lot of sympathetic overactivity in order to stimulate the counter-regulatory hormones to bring out the glucose, especially epinephrine and glucagon. And another symptom is due to decrease in the glucose level, which we call it as a neuroglycopenic symptoms. Now, especially when the neuroglycopenic symptoms appear, patient starts having cognitive impairment. He feels drowsy, he can have hallucinations, and gradually the patient will land up in coma. Sometimes the patient could have psychiatric manifestation. Now, this patient can have seizures. There could be, now due to sympathoadrenal activity, the blood pressure can go up. It could be bounding blood pressure, and this can lead to cardiovascular event or cerebrovascular events. Now, this is a short-term and acute complication. Long-term complications are, there has been suggestion that those patients who get recurrent hypoglycemia, or I would say that they are not in time in range and that the glycemic excursions are too high, they have got a risk of major macrovascular events, including CV mortality. Fear of hypoglycemia, if the patient, you believe me, if the patient gets 2 or 3 episodes of hypoglycemia, that becomes a big problem in controlling the blood sugar meticulously, because the patient becomes so fearful of hypoglycemia, he doesn't aim to control the blood sugar. Of course, if the patient is fearful of hypoglycemia or his life is interrupted by frequent hypoglycemia, he has got an improper quality of life. There is a defensive eating, snacking, and the patient gains weight. Of course, if you have a poor quality of life and you are frequently sick due to you have got restriction of employment, driving restrictions, personal interrelationship is disrupted, and so on and so forth. So the complications of hypoglycemia could be acute, life-threatening, or it could be a chronic, which could be long-term hypoglycemia. And no doubt that more than 6 times increase in the death due to diabetes has been attributed to patient experiencing severe hypoglycemia in comparison to those who do not experience severe hypoglycemia. So hypoglycemia is a very, very important thing which you should be aware of in the management of any diabetes management program. What is the impact of hypoglycemia? This is a very busy slide. I will walk you through that if the person gets hypoglycemia, there is a sympathoadrenal response. And this sympathoadrenal response leads to increase in the workload of heart, there is increase in the blood pressure, there is increased oxygen demand, increased contractility. So this is on one hand. Another hand, if there is a lot of epinephrine, adrenaline release, the heart rate becomes variable. There is tachycardia, there could be ventricular tachycardia, there could be atrial fibrillation, there could be QTC prolongation, there is flattening of T wave, and sometimes in the patients who are predisposed to a myocardial event. Now, if the patient's glucose goes low, 7 or something like that, the patient starts getting neuroglycopenic dysfunctions. There are seizures, there are functional brain failure, brain injury, and prolonged cerebral attacks. Now, this is in the acute setting, which is also affecting the neuroglycopenic symptoms, affecting the eye, which can lead to diplopia, because retina also is very, very glucose sensitive. You can have diplopia, retinal insensitivity, retinal poor response of retina. But if the patient is getting minor episodes of hypoglycemia, what will happen? In the long run, it will cause increase in the inflammation. There is increased C-reactive protein, increased interleukin C, vascular endothelium and growth factors. And at the same time, there will be increase in the coagulation abnormality with increase in factor 7, neutrophil activation, and platelet activation. Along with the endothelial dysfunction and decrease in vasodilatation, it will cause increased propensity to macrovascular disease. So hypoglycemia can acutely affect the cardiovascular health of the person, as well as it chronically affects the cardiovascular health of the person. Now, psychological impact, you can imagine, if the patient gets this type of feeling frequently, recurrent hypoglycemia, it has got, the patient feels that he is powerless. He always is anxious about if he gets these symptoms again. Or the patient's family also is scared of this hypoglycemia, and they have, sometimes they remain awake throughout the night that the patient will get hypoglycemia. And of course, acute hypoglycemia, if one has witnessed and the patient has gone into coma, this is a devastating for the family. So this all leads to a lot of psychological impact and consequently on the control of the diabetes. And this leads to decreased adherence to diabetes. And it has been seen that those patients who get single episode of hypoglycemia, they are wary of getting a very tight control of blood sugar. And it's very difficult to motivate them or to adhere to the treatment because they always fear that they will get hypoglycemia. So there is a lot of scope for education, educating the patient about hypoglycemia and managing the patient so that he gets lesser and lesser hypoglycemia and the patient could manage his own hypoglycemia. So if you see those patients, this is a study which clearly shows that those patients who have got recent hypoglycemia, 52% of the patients reported medium to low adherence with the medication, a quarter of whom had low adherence. So if you look at this graph, if the patient who has got recent hypoglycemia, almost 20% have got very low adherence. Almost 50% will have medium adherence. Is compared to if you look at the blue bar, the last 3 diagrams, which shows that patient never has hypoglycemia, the adherence is very high. This is the blue bar. Adherence is as high as 50 to 60% for the treatment. So this is the importance of educating the patient with for hypoglycemia and not allowing the patient to go into hypoglycemia. Now, if the patient gets hypoglycemia, the patient should not get panicky, the attendant should not get panicky, and the doctor should not go panicky so that the patient starts rolling between hypo and hyperglycemia. What do? First of all, you should have strategies to prevent hypoglycemia. And for that, you have to identify the patient who are at high risk for hypoglycemia. Then you have to make right therapeutic choices. As I told you, there are only two regimens. If there are these two drugs are in the treatment regime, you get severe hypoglycemia. These are either sulfonylurea or insulin. A regimen without any of these two is not likely to cause severe hypoglycemia. So in a patient with high risk of hypoglycemia, try to manage with drugs which do not cause hypoglycemia. And if the patient develops hypoglycemia, you should have tools to treat the patient. So how do you prevent? Patient education. Every time the patient comes to you, you should educate about the symptoms of hypoglycemia, and not only to the patient, but to the attendants, and how to manage it. Now, how the patient is going to, or the attendants are doing a frequent blood glucose monitoring, which is paramount in preventing the episodes of hypoglycemia. So, patient is educated.
Sir, you are not audible. Sir, you're not audible right now.
वीडियो ऑडियो दोनों खोल।
वो शेयर स्क्रीन करो वहां से, अब करो।
अब यहाँ खोलो ना यार, इसको शेयर स्क्रीन करो। ठीक। Sure. ठीक। Am I audible? Am I audible?
Yes, sir, you are audible, sir. Please, yes, sir, you are audible. Please go ahead, sir.
I'm sorry for the technical glitch. It was
No, no
beyond
problem,
my
sir. Please, please,
control.
please, sir.
Okay.
Please.
So
Okay, sir,
we
you are
are
audible.
on a very important slide. Treatment of hypoglycemia. Now, if there are two options. One is you give the patient glucose. Don't give a lot of glucose. You have to give 50 to 20 grams of glucose. That is 4 teaspoonful of glucose. Or if the patient is on insulin therapy and he gets hypoglycemia, patient could be given a pre-filled syringe of glucagon, which is to be injected, which can immediately take care of the hypoglycemia. The caretaker should also be informed and told about the symptoms. Sometimes these patients, they have to carry a card that of hypoglycemic and how to manage. I'm a diabetic, I'm in hypoglycemia, and what is to be done. Now, once you have given the patient glucose, measure the blood glucose after 15 minutes. And if blood glucose is again low, you give the patient another dose of glucose. So don't load the patient with a lot of glucose, otherwise the patient will swing between hypo and hyperglycemia. And if the patient is on sulfonylurea, it causes delayed hypoglycemia because of tonic release of insulin. You have to continue to feed the patient, or the patient has to be given IV fluids. Otherwise, the patient can get late onset hypoglycemia, which again the patient will land up in. And sometimes during the episodes of hypoglycemia, when there is sympathoadrenal activation, patient blood pressure shoots up, patient could get stroke, a patient could get MI. So that is to be prevented. Now, DPP-4 inhibitors, vildagliptin, and other DPP-4 inhibitors, they do not cause practically hypoglycemia. And if hypoglycemia is there, it is very, very minimal. So this is if you look at comparison between sulfonylurea and vildagliptin, what you find is, as compared to a patient who has got a glycosylated hemoglobin of less than 7, where the incidence of hypoglycemia is 1.9 and 18.9 in sulfonylurea group. Even in elderly patient, you find the hypoglycemia is only 1.9 or 1.7%. You may be saying that I'm mentioning that the patient do not get hypoglycemia. And let us go to the next slide. What you find is there is practically no severe hypoglycemia. It means needing assistance or the patient going in coma with DPP-4 inhibitor, vildagliptin, as compared to sulfonylurea, which is as high as 10%. So if hypoglycemia occurs, it is very, very minimal, and the patient can manage the hypoglycemia on their own. So except for sulfonylurea and insulin, I am keep on reiterating, because the moment patient is on sulfonylurea or insulin, you should be cautious about, or the whole drug regimen contains any of these two drugs, you should be cautious about hypoglycemia. So lower incidence of hypoglycemia continued, 18.2% with glimepiride as compared to 2.3%, and over 2-year period when either vildagliptin is added to metformin or glimepiride is added to. So in a group where sulfonylurea is added, glimepiride is added, the incidence of hypoglycemia is 18.2% as compared to where vildagliptin is added, it is only 2.3%, and most of these are mild hypoglycemias. So based on this, the guideline recommend that individuals with high risk of, who are individuals with high risk of hypoglycemia, individuals with long duration of diabetes, individuals who are elderly, individual who gets frequent hypoglycemia in the past, patient with autonomic dysfunctions, all these are at high risk of hypoglycemia. And then you have to use the drugs which do not cause hypoglycemia, or if you are using these drugs which can cause hypoglycemia, you should be very, very cautious, and the patient as well as the patient attendant should be taught about hypoglycemia. Now, what is the RSSDI ESI, Endocrine Society of India consensus guideline? Intensity of hypoglycemia risk you should be monitoring. Patient characteristics is very, very important. Elderly patient, long duration of diabetic. In long duration diabetic, there is also a concern of hypoglycemia unawareness and which drug you are using. And based on that, you have to educate the patient and keep on monitoring the glucose, and especially if the patient are fasting. So to conclude, it is important to manage the risk of hypoglycemia in type 2 diabetic patient. Early recognition is very, very important. You should not allow hypoglycemia to perpetuate, which can lead to irreversible brain damage and sometimes major cardiovascular events. Self-monitoring of blood glucose is a very, very important tool in knowing whether this hypoglycemia is there or not. And now you've got CGMs, which can pick up asymptomatic hypoglycemia. Always select an appropriate regime, because hypoglycemia is iatrogenic, and any iatrogenic problem is detrimental for the patient. Appropriate educational program, this is very, very important for healthcare professionals and patients with diabetes is important, and precisely what we are doing it. An effective strategy to maintain good glycemic control without or minimizing the risk of hypoglycemia is very, very important to prevent diabetes-related complications. And one of the drugs which can do that is vildagliptin. Thank you so much for patient hearing.
Thank you, sir, for a wonderful presentation. I think we have time to take one or two questions. I have one or two questions with us from the audience side. The first question is how to select a patient of type 2 diabetes mellitus for GLP-1 analog. Kindly guide us, sir.
GLP-1 analog is a wonderful drug, especially for obese patients. And this is one drug, GLP analog, and now we are getting GLP analogs in oral formulation also, GLP analog and SGLT2 inhibitors. Are these two drugs who have got proven benefit in cardiovascular health of the patient. This, for the first time, we have got drugs which are causing benefit in the cardiovascular outcome as compared to neutrality or detrimental effect. At the same time, they are causing loss of weight also. So whenever the patient is obese and you fear hypoglycemia, if you want an injectable treatment, you can use GLP receptor agonist, which cut down the appetite, decreases the satiety, and weight loss of the patient, along with cardiovascular benefit, with a reasonable about 10 to 15% reduction in the glycosylated hemoglobin. So, but one problem is that patients may initially have GI intolerance, so you have to go slow, build up the dose, and educate the patient. So it's a wonderful molecule, especially in the patient, and it has moved up in first if the patient has got a pre-existing heart disease, and especially if the patient is obese, go ahead and use GLP receptor agonist.
Sir, the another question is how to use a ultra long acting insulin and prevent hypoglycemia.
Now we have got wonderful insulin. Now we have got second generation basal insulins. These insulins are peakless insulins. They have got a flat PKPDs. They do not fluctuate. And due to that, the incidence of the only thing which has improved over years from NPH to first generation basal insulins to second generation basal insulin is lesser and lesser incidence of hypoglycemia. So one is that by mere their nature of the molecule, which is causing a flat peakless profile over extended period of time, they have got less chance of developing hypoglycemia. Of course, they can cause hypoglycemia. For that, you have to do a cell blood glucose monitoring. Maybe at times you can do we usually say that the patient should be doing a 7 or 8 point profiling of the blood sugar. If the patient is on insulin, one day or other, the patient should be doing a 7 or 8 point profiling if you do not have access to CGM. That pre-breakfast, post-breakfast, pre-lunch, post-lunch, pre-dinner, post-dinner, 10 a.m. And sometimes if you are getting early morning hypoglycemia or you've got a lightheadedness, you can do a 3 a.m. blood glucose. By this, you know what is your glycemic profile and you can adjust your insulin dose accordingly. And the next generation, this is like a Degludac or what we have got 2GO now. They are peakless and they have got a lesser risk of hypoglycemia as compared to the previous generation long-acting insulins.
Thank you, sir.
I would like to ask one question, sir.
Sir,
Just a minute.
Yes, sir.
Yes, sir.
Sir, my question is, voice is actually,
Sorry?
sir, just a minute.
Yeah.
Dr. Amit, you are not audible. Please, yeah.
Am I audible now?
Yeah, now it's okay. Yes, you can go ahead with your question, please.
I just wanted to ask one question. When the problem is when we have insulin which is acting more than 24 hours, then how do we regulate the dose and what should be the timing of the next dose? Do we need to alter the dose each and every time?
Dr. Amit,
Yes, sir.
you are.
I'm cardiac surgeon, sir.
Oh, Amit.
Yes, sir.
Okay.
Yes.
No, we don't have to because this is the half-life of the molecule and its duration of action is one is acting for more than half-life is 24 hours, another has got a half-life of 42 hours. So they have got a very long duration of action. But the only thing is that they take some time to reach to a steady state, like 4 or 5 days, and subsequently, the amount of drug which you put in, the same amount of drug is being pushed out. So you reach a steady state in 4 to 5 days. Now, what you have to do is you have to give the same dose of drug, and based on essentially this is a drug which is preventing hepatic glucose output, and it is providing a constant supply of insulin, like in your body where there is a constant insulin secretion, and over and above when you eat meal, there is a spurt of insulin release. So this is a basal insulin release, which is essentially a peakless insulin in your body, and it is mimicking your physiological profile. So the same dose of insulin is to be given every day at a fixed time, whatever. With the current molecules, you have got a flexibility of giving it like with the 2GO, or you have got a flexibility of 3 to 4 hours. And with Degludac, you have got a flexibility of almost up to 12 hours or more, even 24 hours you can be flexible. So that's one thing, but the dose remains the same because of at the steady state, the amount of drug which you put in, the same amount of drug is excreted out and there is a depot. So this is maintained throughout. So you don't have to change the dose frequently.
So thank you.
Thank you, Dr. Madhukar Rai, sir, for your enlightening presentation. Over to you, Dr. Amit, for delivering vote of thanks.
Thank you for all the participants to participate in this event. It was a very nice and informative evening. I would like to thank to Dr. Madhukar Rai, sir,
who has given his presence in this meeting for a very long time, and he has enlightened us in many ways in diabetes and endocrinology, and he has been an inspiration for me since my MBBS time. Thank you, sir. I would
Thank you.
like to thank you, sir. I'd like to thank all the company personnels for participating in this event, and especially the Novartis, Enormit Biosciences, then JB Chemical, then Elnish Life Sciences for their participation and making this event successful. Hope this is good for them also. Thank you all, and let's end this evening with a good note. And we'll join very soon on World Heart Day with updates of cardiac care. Thank you, and we should end our meeting right now because it is very late and we should go for dinner right now. Thank you.
जो नए नए